Kotsaliudaki. I am a neonatologist here at UCLH in London, and I'm in charge for the education and treasury, working with the rest of the faculty of the N3. And I will be chairing the first sessions with Mark and Chris, and I'll let them introduce themselves, and Pam as well, that is with me. So maybe Pam can introduce yourself quickly.
Yes, so I'm Pam Stepney. I'm the neonatal dietitian at UCLH, and I work with Christina. And I'm also the dietetic representative for the N3.
Mark?
Hi, I'm Mark Johnson. I'm a neonatologist in Southampton, and sort of chair of the N3 at the moment. Chris?
And
hi everyone, I'm Chris. I'm a neonatologist in Leeds, and I'm also one of the committee members of the N3, and also look after the website.
Wonderful, thank you. And just a little bit of housekeeping. During the lectures, may I ask everybody to keep the cameras and the speakers off, so then there's not going to be echo or a noise. And if there are any questions, please post them on the chat. And we will run a panel discussion just before the break, after the first 3 lectures, with the presenters, the speakers participating, and then another small panel discussion after the break and after the second round of the 3 lectures. We'll keep on reminding you to post your questions, but yes, if you keep yourselves mute and the cameras off during the speakers. And I think we're ready to start. Mark Johnson will be presenting first. Mark is the chair of our N3 network, and he's a consultant neonatologist in Southampton with more than 12 years of experience in neonatal nutrition, with interest in neonatal growth, body composition, as well as the nutrient intakes. But today he's going to tell us about a new topic that he has interest in, and is about reflux and the management of reflux. I'm glad that Mark can tell us what we should do for reflux, and what we should be thinking when we think about reflux in neonates. So Mark, all to you. Thank you.
Thanks very much, Christine, for that nice introduction. As you've alluded to, I'm not an expert on this subject, but I'm going to talk about it anyway. I'm not sure I'm going to give you loads of answers, and I guess that might be the point of my talk. And it's quite a controversial area, because I think everyone does things slightly differently, and I think that probably just highlights the fact that we're not really sure what we should do. So what is reflux? So I've got these definitions from the NICE guideline. There's a published NICE guideline on this. So there is just what people call gastro-oesophageal reflux, which is, as it says up on the slide, just passage of gastric contents into the esophagus. And it's pretty common, and it can happen to everyone. We've all had a bit of heartburn from time to time. It tends to happen more after you've eaten. And in lots of infants, it's associated with a tendency for what people refer to as over regurgitation. So bits of milk coming up everywhere. And anyone that's had a baby at home will be familiar with the smell of stale yogurt that you get, because they bring up little bits of milk all the time. And how bad that is variable between different babies. And there is obviously a point where that becomes a problem. That's different to gastro-oesophageal reflux disease, or at least it is according to NICE. So that's when the symptoms of reflux become enough to merit medical treatment, or to cause complications. And that's quite vague, because obviously medical treatment is us deciding to do something, and we'll all decide to do something at different points. But it gives examples of things like discomfort or pain, which again is quite subjective. Clearly, things like reflux-associated complications like ulcer-esophagitis or pulmonary aspiration perhaps are more easy to diagnose and more likely to push you towards doing something about reflux. It's really common, as I already alluded to, and it's common in babies because all their food is liquid. They spend all their time lying flat, and they have underdeveloped esophageal sphincter mechanisms. So it's quite likely that stuff's going to come back up just as part of the normal course. We don't know exactly how common it is, but we think it's around 50% of infants under 2 months, perhaps a little more in the older ones, perhaps because they get more milk. And it reduces by the time they're a year of age. And in fact, the natural history of reflux generally is that it gets better as infants spend more time sitting up and less of their food is liquid. There's been a systematic review that suggests it's present in about 25% of infants on a daily basis and tends to decline over that first year. Other studies reported it as high as 50%, which if you do the maths means there's about 300,000 infants affected by it annually. So it's potentially a big problem, at least problematic. Reflux is a big problem. As I said, some of it is probably normal and not that problematic. Because it's so non-specific, the symptoms, it often is overdiagnosed, or perhaps not overdiagnosed, but perhaps overtreated. So people do something about it at different thresholds than others. And so lots of infants get prescribed medications without any clear evidence of disease. And as I mentioned, in most cases, it does tend to get better by itself as children get older. This is from a recent sort of consensus statement from a working group in Espegan, I think. And one of the things they looked at in terms of their things they believe statements included the prevalence, and so they've done some work. And it suggests the prevalence of what they call regurgitation, so kind of your most basic form of reflux, is about 50% in those babies under 2 months, as I mentioned earlier. It goes up and then comes down a bit towards a year. In terms of preterm infants, which I guess most of us working in neonates will probably be seeing more of than term infants, they're at much more increased risk of it because they have even more immaturity of their lower esophageal sphincter. They don't have really effective esophageal peristalsis, and they have relatively abundant milk intake in terms of the number of mils per kilo they'll get. So some of them might be on 180, 200 mils per kilo of milk compared to 150 or less in bigger babies or older babies. They also therefore get greater gastric distension, and they get their symptoms of reflux are perhaps easier to spot, partly because we monitor them. So we see episodes of apnea, we see episodes of respiratory distress with DSATs more commonly, and that often makes us keep them in hospital a bit longer. A study in the US looked across 33 different tertiary neonatal units, looked at this, and they found that there was a 13-fold variation in diagnosis, as I kind of suggested, so anywhere between 2 and 26%, which I guess highlights how subjective some of these things are. Babies that were diagnosed with GORD stayed a month longer, and they also tended to have more costs. And they reckoned that having an infant getting diagnosed with gastro-oesophageal reflux disease increased the cost of their stay by $70,000 because of the medication and because of the prolonged stay. So it's potentially important in preterm babies as well. This is just another study looking at how common it is across different gestation ages. And essentially it shows you on the left here, this is using something called the IGERC, which I'll come on to, which is a scoring system which attempts to make the diagnosis and measurement of severity of reflux a little bit less subjective. And you can see that more premature babies under 32 weeks around birth have a much higher reflux score than those born a bit later. And if you look at how that changes over time, you can see that even after those preterm babies at less than 32 weeks go home, they have a much higher incidence of reflux. Even up to 4 to 6 months of age, they're getting higher reflux scores than the more mature babies. So it is something that affects preterm babies more than it does term babies. Is it a problem? Like I said, it's kind of normal to some extent, and it's been estimated that most neonates will have 2 to 3 episodes of reflux per hour just as part of what is normal for them. That will change depending on how frequent they're being fed and how they're being fed. So having things like NG tubes in will affect your tendency to reflux. The symptoms seem to change in relation to the infant as well. So if they're spending more time sleeping, they might get more reflux because they're more flat on their back. But equally, if they're more active, they might get more reflux because of the changes in abdominal pressure. So it seems to go up and down with the baby, independent of other things that we're doing. And Shalini's going to talk about this more in the next talk, but we know that regardless of whether it's normal or not, lots of the symptoms that you get from gastro-oesophageal reflux can be distressing for the infants and the parents because of the crying, the feeding difficulties, and the poor sleep and the anxiety, which can mean families affected with this problem seek healthcare more often. I talked right at the start about the difference between just reflux and reflux disease, and there is some statements on this. So the ESPGHAN got some guidelines that have been updated a couple of times, and they define gastro-esophageal reflux disease as gastro-esophageal reflux associated with bothersome symptoms, which is a slightly Victorian way of putting it, isn't it? But the problem with that is that what constitutes troublesome or bothersome is vague, because everyone's threshold for when they think this is bad will be different, both in terms of the parents and the caregivers. So something more objective has been suggested. So Brandon Plass, who's one of the authors of these guidelines, who's done a lot of work on reflux, suggested that it's troublesome if it's happening more than 4 times daily over a more than 2-week period between 3 weeks and 6 months, which is quite complicated. But what they're trying to say is it's something that's recurrently happening, and that's what makes it more problematic. Clearly, if you're getting gastrointestinal sequelae like esophagitis or hematemesis or stricture, that's much less subjective, and you can see that this is a problem and would need treating. And similarly, the extraintestinal sequelae like life-threatening events, apnea, which we see commonly in preterm infants, are again going to push people towards doing something about it and make a diagnosis of troublesome disease. But as I've said, it's complicated, particularly in the NICU, because there are lots of presenting symptoms for potential reflux. There's the ones we know about, the gastrointestinal ones, the regurgitation or bringing up milk, abdominal ascension. But then there's your bradycardia and your apneas and your breathing, your cardiorespiratory symptoms, which are the ones that probably trouble us the most on the neonatal unit. But we might also see sensory problems like irritability and back arching, which the nurses and parents will find distressing and will report to you because they feel we need to do something about this. And then there can be sneezing and swallowing and feeding difficulties, such as sneezing or coughing. But lots of preterm babies do all of this without anything to do with their feeding, because we know that they're prone to apnea by being premature, for example. So actually attributing some of these symptoms to actual reflux events is difficult. I think we've all been called to a baby who just have an apnea where everyone sees milk in their mouth, but it's variable. And lots of these are due to the vagal response you get from having that bit of milk in your mouth. So as I mentioned earlier, people have tried to be more objective, and there are lots of scoring systems. This is 3 of them. I'm going to talk about the bottom one. They're all kind of similar, but just as an example, there's this thing called the Infant Gastro-Esophageal Reflux Questionnaire Revised. I'm not sure what the original one was like. The IGERC-R, and it's this questionnaire here. It is still quite, you can see from the questions, it's going to still be quite subjective, because you're asking the caregivers to say how often they think it's happening. Rarely, often, sometimes never is quite a lot of the answers in terms of when they refuse a feed, whether they're spitting stuff up. So it's due to there's going to be some recall bias here, and people's interpretation of what never, rarely, or sometimes means will be different. Interestingly, what you can see from some of these questions is it doesn't perhaps capture some of the things you see in preterm babies. So, you could argue there should be a question on here about whether the baby's having apneas or bradycardias or desaturations in relation to their reflux. But I think it gives a reasonably good idea about how much it's happening and how severe it is. And it's been shown, so this is the original publication for it, it's been shown to be valid as a measure of reflux. It seems to relate to things like pH probe severity, those sorts of things. So there is a relationship between actual reflux and the scores you get on this questionnaire. And people have actually even calculated a clinically meaningful difference by reviewing the literature and looking at what studies were able to detect and the differences. These are all studies where there was treatment done of some kind. And they've estimated that a change in score of about 6 is probably a clinically important difference, but actually even 3 to 4 might represent something important in terms of improvement in symptoms. So there is a kind of way of looking at it in a more methodical manner if you choose to use these questionnaires. So I mentioned NICE right at the start. So they have quite a comprehensive and lengthy, as is often the way with NICE, guideline on reflux and how you should diagnose it and what you should do. They give those definitions I showed you at the beginning, and they make a big emphasis of some of the things I've already said. So we know that reflux is a normal physiological process in infancy and often doesn't need any investigations or treatment. And actually, the guideline generally is against investigations unless you're seeing quite severe problems or secondary effects. And they feel you can do a lot just by advising parents about these things and reassuring them that it's okay and it will get better. But equally recognises that a small proportion of infants, it might be a sign of distress and it might cause problems, and that's when you'd call it gastro-oesophageal reflux disease. And gastro-oesophageal reflux disease is more common in certain conditions. I've mentioned preterm infants as one of them, but there's also things like neurological impairment. We know children with things like CP have this more problematically and more frequently. But if you've had repaired tracheoesophageal fistula, or atresia rather, or a diaphragmatic hernia, or if you've got chronic disease, these are all more common. These all more commonly have reflux disease. So NICE say that you should give some advice. You should be to your parents and carers that these things are normal, and actually that's what most nurses on my unit get from me. They say we think this baby's got reflux, and I say of course they've got reflux. They're a baby, which I think they find quite irritating. Maybe I should not do that anymore. But we know it's common, like I've said, it tends to begin when they're young, as we all know. It can be quite frequent, it gets better with time. So all these things I've said already, and this is what NICE says you should tell people to reassure them that it may not need anything doing. Generally, it's kind of suggesting you try and do nothing unless you have to. And what they say if you're going to do something, so if you're formula fed, they say you should do things that we probably are quite good at doing on neonatal units, but perhaps are harder to do in community dwelling babies, which is looking at how they're being fed and thinking about whether you reduce the feed volume or change the feed frequency so they're having smaller feeds more frequently. And these are certainly things that I've done on the NICU, I'm sure we've all done it, and that can often make quite a big difference. But equally, is not always sustainable, because actually if you reduce the feeds down to 2 or even 1 hourly to see if it works, it might work, but you can't feed a baby 1 to 2 hourly for the duration of their stay, and they certainly can't do that when they're at home. It then suggests if you're formula fed, you could offer a trial of thickened formula. I think my favourite named formula of all time is SMA Stay Down. The marketing guys at SMA were having a great day that day. But these things stick in on contact with stomach acid and are less likely to come back up. So that's what you do if they're formula fed. If you're breastfed, if you're breastfed, clearly if you're a baby who's preterm, who's being fed breast milk and an NG tube, you can look at some of those options in terms of feed volumes and frequency. But if you're actually being breastfed, that's harder. And so what they suggest in that instance is that you should consider alginate therapy. So that's Gaviscon, basically. And that you can also do this for formula fed babies if you tried the things above here and they haven't worked. And it suggests trying them for just 1 to 2 weeks. If it's working, carry it on. But equally, if it's working and you carried it on, do try stopping it every now and then to see if the baby still needs it. And it's not without problems. I think we're all aware that if you give babies Gaviscon, they have a tendency to get constipated, and then you have to give them something for the constipation, which is another medicine. The guys from Nottingham, John and Cellini and Ping, had looked at this a few years back and have done a systematic review to see if infants up to this age of 6 months respond to feed thickeners. It was a Cochrane review, and actually, this is just one of the many forest plots in there, but it suggests that these are all the different things you can thicken your feeds with, and there's alginates there, Gaviscon right at the bottom, and you can see generally all of them seem to have some effect. Only alginates and cornstarch seem to be significantly making a difference towards posseting, in this case, symptoms of reflux. But taking them all together, you can see that it suggests that thickening your feeds in some way does seem to reduce your frequency of reflux episodes. And actually having 2 less episodes a day, which is what that combined result shows, is perhaps important to some, may well be important to parents and caregivers, even if it's just 2 less times when they're having to deal with this. And there were lots of other forest plots in there showing generally beneficial effects. And so they concluded that there was moderate certainty evidence that feed thickeners should be considered if regurgitation symptoms persist, because it looks like it reduces the episodes by 2, and that might be important. But as with lots of things in these patient groups, more work is needed to see if we can work out which one is better and how to give it. And there's an elephant in the room here that I haven't mentioned, which some of you are probably thinking about, which is what about cow's milk allergy? So lots of babies who have symptoms of reflux, people will often wonder is this because they're not getting on with the cow's milk protein present in their milk? And is that what's causing their unsettledness and problems? And if I get them off the cow's milk, is that going to make it better? And that's tricky. I think cow's milk allergy is a thing in some babies, but it often comes with other symptoms, particularly things like blood in the stool, abdominal distension, things that you might not necessarily see with just reflux alone. So that is complicated. NICE have actually got quite a strong view on this. And what they say is that there is a widespread belief that that gastro-oesophageal reflux can be caused by intolerance to cow's milk. And so some people will prescribe specialist formulas for this, but that's tricky because specialist formulas are more expensive. And also, if you're breastfeeding, then the implications for mum going onto a milk-free diet or temporarily switching to formula, that's not necessarily a great thing either, because we want these babies to be breastfed. So this is complicated. And so NICE aren't keen on it, and what they make a big thing about is they say there's actually no evidence for the cost effectiveness of this approach. So there's no evidence that changing formula milk in this situation is beneficial at the moment. Doesn't mean that there won't be, but it doesn't look like it's effective. There's no evidence, as opposed to evidence of absence. There's an absence of evidence. So this is in the section on the guideline about more research being needed. And that's probably all I'm going to say about it, because it's complicated. And I think giving specialist cow's milk-free formulas to these babies for reflux is something you need to consider carefully. And there will be some babies where it's beneficial because of the other symptoms you get with it, but it just needs a bit more thought. And I don't think it should be a routine treatment for just reflux. What they say next about further management is they say don't offer acid-suppressing drugs like proton pump inhibitors and H2 receptor antagonists to treat just regurgitation in isolation. But consider a 4-week trial of those drugs if you think they have overt regurgitation with another symptom, such as difficulty feeding, distressed behaviour, and faltering growth. And clearly, distressed behaviour is probably the one that gets people thinking the most about doing stuff. And I guess for preterm infants, you would include, in addition to this, you might think about whether you could having frequency of feed-associated apneas and bradycardia desaturations. It might be something that you'd put in there as an additional feature that pushes you towards treatment. And they say once you've done 4-week trial, then you need to think about whether you do some tests if it's not getting better, or whether you carry on treatment. And the tests they talk about are things like endoscopic examinations to look at esophagitis. And this is more applies to older infants and children, certainly not something you think about in preterm infants in the first instance. And they say don't give metoclopramide, domperidone, or erythromycin, i.e. prokinetic agents, because the potential benefits are outweighed by the risk of adverse events. So don't use those, essentially. So in terms of the acid suppression drugs, there's 2 types. There's H2 receptor antagonists, your cimetidines and your famotidines, which block histamine receptors on gastric cells. These are less commonly used these days in preterm infants, partly because there have been some studies, particularly on ranitidine, that have shown some concerns, which I'll come on to. And partly because if you are genuinely interested in suppressing acid in the stomach, then you're better off using a proton pump inhibitor, because we know that they work more effectively in doing that one thing of reducing stomach acid and secretion, particularly acid. And that's your omeprazole and your esomeprazole, your lansoprazole, and all your prazole drugs. And they irreversibly block the hydrogen potassium ATPase pump in your gastric cells. They actually block it irreversibly. It means it doesn't come back until the cells have made some more of it. So it works for quite a long time. This is a nice diagram I got off the internet of a gastric cell, and you can see your proton pump inhibitor works here across the sodium potassium ATPase, but you can also see at the top you've got your histamine receptors, which is where your cimetidine type drugs will work. And PPIs are probably these days the commonest agent people will give for reflux. They've got a good evidence base in adults, but there is no robust evidence that they are effective or safe in infants. But people use them because on paper we know they reduce the acid, and we know they work in adults, and that's why people use them. A recent Cochrane review showed there was no clear benefit of omeprazole or esomeprazole on reflux symptoms compared to placebo. Although these were 2 studies that were very small, but the individual studies themselves showed no benefit, particularly the esomeprazole study didn't show a difference. That's the review there by Mark Tye and colleagues, and you can see, I've already kind of said what it shows, but essentially there was no benefit from any of them. and so they don't recommend giving them to infants. So they say there is low certainty evidence about improvements in changes in pH. There's no data on endoscopic changes that have benefited from them. And if a medication is required, there's no clear evidence based on the data which one you should use, and there's no evidence for symptom improvement. There are also some concerns about PPI. So although the main concern is, if you think about the mechanism of action, they reduce the acid in the stomach, but for preterm infants who are having apneas because of the milk coming back up, it's not going to stop that happening. It's just going to make it taste nicer. So it reduces the acid. It might reduce the volume slightly as a result of reducing the acid, but it won't necessarily stop the actual milk coming back. And if the actual milk coming back and causing a vagal response is what's causing all the problems for your apneic preterm infant, you can see that omeprazole might not do very much for that. But if they're bothered by the acid in it, then it might do something. And I guess that's what we don't know. There are also some concerns about the impacts of reducing your stomach acid, because it's there for a reason. It destroys ingested bacteria and viruses, and its use has been associated with increased respiratory tract and gastrointestinal infections in infants. And it's also been associated with necrotizing enterocolitis and fungal sepsis in very preterm infants. And it might well impair the absorption of certain vitamins and minerals that require an acidic gastric environment to aid their absorption later down in the intestine. So you might get impaired growth and bone development, particularly because it affects things like magnesium. And so you might then be at increased risk of fractures. And there's been various publications on this. This was a systematic review looking at gastric acid suppression in the instance of necrotizing enterocolitis. There was only 2 studies, but they both suggested that having gastric acid secretion increased your risk. Your gastric acid secretion suppressed with things like ranitidine and omeprazole increased your risk of necrotizing enterocolitis. There was another paper that was slightly more ambitious and looked at lots of different things, but essentially showed that infants who've been exposed to inhibitors of gastric acid were more likely to get late onset sepsis, they were more likely to get fungal infection, and they were more likely to get NEC and ROP. So that puts me off certainly using them, using suppressed acid. This is a review article that suggests that looked at all the evidence of using just specifically proton pump inhibitors that shows they increase the risk potentially of gastrointestinal respiratory tract infection in infancy, vitamin B and magnesium deficiency, and fractures. And this is another more recent article looking at children who have fractures, and it's a cohort study, so it needs to be interpreted with caution, but essentially the ones with fractures were more likely to have had proton pump inhibitors. So stomach acid is probably important, and we probably shouldn't suppress it unless we're certain it's the right thing to do. Despite what NICE say, and despite the weak evidence, people do use them. So there's been various surveys that show about 82% of people in Europe prescribe drugs inappropriately for reflux. Similarly, in the UK, there's quite a lot of variation, and lots of people, up to 40%, will give anti-reflux medicines. Analysis of UK data suggests 37% of preterm infants get some sort of anti-reflux medication, not always associated with a diagnosis of reflux. That last one comes from this paper by Charlene and colleagues, using NNRD data and looking at infants prescribed different products, as you see down the left here, but also what their discharge diagnoses were in terms of whether they're actually diagnosed with reflux, which is how we know that some of these babies didn't have a diagnosis of reflux despite getting an anti-reflux medicine. And what you can see is that in the babies less than 28 weeks, which from some of that stuff I showed you are the ones where you might be most concerned about using, you can see that quite a high percentage, so 64% and 49% of infants are getting H2 receptor blockers or PPIs, sorry, 20% PPIs. And this shows how the trends of prescribing changed over time, and you can see we're giving more and more PPIs and slowly giving less ranitidine, and we've had a massive drop in prokinetics because we are worried about those because of some of the stuff that's come out in the recommendations by NICE telling us not to use them. And you can see that over half the infants born less than 20 weeks get anti-reflux medicines. So in summary, reflux is common, especially in preterm infants, and to some extent is normal. It's hard to quantify. There is some evidence for use of thickeners and alginates if simple measures fail. but the evidence for pharmacological management is lacking. We don't know that it works. We don't know that it's doing the right thing in terms of what we're interested in preterm infants, and it might cause some harm. But despite that, we know people are using it quite commonly. So we need more evidence. And just as a quick sort of plug and to get a bit of feedback, maybe in the discussion, there's a recent call from the NIHR for people to do research in this exact area. So they want proposals for evaluation of pharmacological therapies for the management of reflux in infants who have ongoing symptoms, despite treatment with things like Gaviscon. And so me and a group of others put in a bid for this. We got through the first stage. We're now doing a bid for the second stage. Because you have to have a snappy name, and I think cute animals and birds are a thing, we've called it the Otter Study, which is a metrazole for treatment of term and preterm infant gastro-oesophageal reflux. So we're looking at both preterm infants and terminal infants who are under 6 months who've been clinically diagnosed with reflux. So that means we leave it up to clinicians to decide that they think their baby's got reflux and they want to treat them. To see if giving either omeprazole or placebo improves symptoms after a 4-week course. To be eligible, if you're preterm, you have to be past 32 weeks corrected. You could have been born more preterm than that, but you want it to be over 32 weeks before you enter the trial. And that's because we were trying to avoid exposing the very preterm infants to the PPIs, given what we know about them from what I've shown you. You have to be fully fed as well. And in term infants, you just have to be under 6 months. You also have to have been diagnosed with gastro-oesophageal reflux, and we would like someone to have tried the other things first. And this is just to show how it's going to work. So once you get into the trial, you get randomized to either intervention or placebo. And after 4 weeks, we measure the primary outcome, and the primary outcome will be your IGERC score using the IGERC questionnaire I showed you. And then once you finish the trial, the clinicians won't know whether you were treated or not, and it'll be up to them to then do what they think is best based on those nice guidelines, whatever they normally do. So it'll be interesting in people's thoughts on that and any questions. Well, I think we're going to do those in the discussion at the end. Thanks.
Thank you, Mark. That was a very interesting talk. You kept well on time.
It's bang on.
Oh. You did extremely well. Excellent. So Selene is here. Maybe we can move to Selene, and then we can take people can post their questions on the chat, and we'll take them just before the break. We can run through. Mark, do you want to introduce Selene then?
Oh yes. Okay. Straight off one thing to the other. Thank you very much. So next, I'd like to introduce our next speaker, who is Professor Shalini Ojar from the University of Nottingham. She's also a neonatologist in Derby, who has done, as you already showed, because I showed 2 of her papers, has done lots of work on reflux and is working with me on the trial I just talked about. And she's going to talk about exploring parents' experiences, attitudes, and understanding of reflux in infants. Thank you, Shalini.
Thank you very much, Mark. And yes, so first of all, I'm going to try and share my slide and see if that works before I say anything else. So let's see. Can you all see my slides as a presentation?
Yes, can now.
And they move. Good. So yes, thank you very much for giving me this opportunity to talk about a bit more work that students working with me have done on gastro-oesophageal reflux in infants. And this time I think this follows very nicely from what Mark has been talking about, because we've done a lot of work looking at data and looking at the evidence behind whether anti-reflux medications are helpful to babies or not. But for me, what was missing is really having a more detailed look at the other aspect of treating a condition like gastro-oesophageal reflux, which is what is the thing that matters to parents? What are their experiences? What is the impact on family life on having a baby with gastro-oesophageal reflux? So I'm presenting this, but I would like to fully acknowledge that most of the work that I'm going to talk about today was done by Catherine McVicar, who was a master's student working with us here at the University of Nottingham. And the main expert behind this work is actually Manpreet Bains. She's a qualitative researcher who's developing an interest in maternal and neonatal qualitative research, working with, again, in our group at the University of Nottingham. So the expertise behind this work is not mine. I'm not a qualitative researcher. I'm more of a numbers and trials person, and all credit to Manpreet for leading this work. So you've already heard, gastro-oesophageal reflux is a common physiological condition affecting many preterm babies. And if it has troublesome symptoms or complications related to it, then we call it gastro-oesophageal reflux disease. But what is the parent's perspective? What is the impact of having a baby with gastro-oesophageal reflux, particularly after we have discharged the baby, or of the infants who are out there in the community? And to get an insight into this, we conducted a qualitative, semi-structured interview study with parents. To just give you a background, first of all, I was surprised to find when I did the literature review for this that there aren't many studies which talk about parents' experiences of having a baby with gastro-oesophageal reflux. But there are a few, and here are the results from one of these to give you a background of why looking at the parent's perspective may be very important in this area. This was a study by Cavello et al., who conducted a questionnaire survey of 62 mothers whose babies had surgery for gastro-oesophageal reflux disease. So very much the worst end of the spectrum of gastro-oesophageal reflux disease. And they reported high levels of psychological distress and state of anxiety. Nearly 55% had scores indicating clinically significant psychological distress, and that 12 months follow-up after the surgery showed that there was significant reduction in anxiety and psychological distress following an effective treatment for gastro-oesophageal reflux disease. They also showed that there was suboptimal mother-child interaction. This study was also by the same group, but part of an RCT of infant massage therapy, in which they used the nursing child assessment feeding scale. Now, the nursing child assessment feeding scale is an observational tool that can be used in the first 12 months of age, and it has 4 maternal subscales, which consists of a number of items, and using that, we can assess how good the mother-infant interaction is during feeding. And what this study reported was that their maternal caregiving subscales, as a measure of sensitivity and response to distress, were actually similar to national norms in the population that had baby with gastro-oesophageal reflux disease as compared to the normal population. However, what they found that as a group, the mothers did not engage in eye contact to actively communicate with their infants or smile at their infants at the same level as women with children who did not have gastro-oesophageal reflux were doing. And the babies themselves also showed a different behavior, that the babies neither attempted to engage with the mothers, nor did their interactions show any specific distress or allaying of distress when the mother tried to support and comfort the baby. In fact, and then they found that this lack of interaction between mother and baby is very similar to the lack of mother-baby interaction that is seen in women with postnatal depression. This was despite that none of these women who were participating in the study were reporting postnatal depression. So this effect was seemed to be completely attributed to gastro-oesophageal reflux disease and the difficult feeding interaction between the mother and the child because of that. So with that background, we thought that we need to understand a bit more about how gastro-oesophageal reflux disease impacts families, and to explore the parental experiences, attitudes, and understandings of the diagnosis and management of this condition. And our plan was to help inform future research as well as future approaches to parental education in this area. We conducted a qualitative study involving semi-structured interviews using a constructionist approach. The study was conducted with ethical approval. And we did this by looking for women who, parents who lived in the UK who were aged 18 or older and able to complete the interview in English. This was a student project, so we were a little bit limited in finding funding for translation. So we limited ourselves to English-speaking families. And they needed to be a family where the parent or the guardian had a child aged under 2 years of age at the time of interview, and the baby should have had a diagnosis of gastro-oesophageal reflux or gastro-oesophageal reflux disease before their first birthday. We recruited parents by convenient and purposive sampling using social media and online forums, as well as Catherine visited the local children's play groups in Nottingham to put out posters to improve recruitment rates. The researchers prepared an interview guide. All the interviews were conducted with full written informed consent. The interviews were completed either on telephone or online using Teams, and each participant received a £15 voucher for participating in the study. This is just the details of how meticulously Manpreet and Catherine conducted the qualitative analysis. Qualitative research is a lot of hard work because everything has to be transcribed word by word, absolutely verbatim, and then has to be reread several times for the research to develop familiarity. Then as a first step, they document their initial reflections. Then they do coding using a software called NVivo, forming themes by collating codes with similar characteristics. And then the themes are mapped again to organize them into specific themes and sub-themes. And this whole process is repeated until the researcher is comfortable that accurate representation has been achieved. And all this is done by two researchers completely independent of each other, and they compare their findings and then continue to repeat the process until they have agreement. So a lot of work was done to get the results of the study. They managed to recruit 9 participants. Catherine had planned to recruit 12, but again, student project limited time, so she had to stop with 9 participants. On an average, she conducted the interviews for 32 minutes, ranging from 18 to 46 minutes. She was able to speak to one father, but most of the participants were mothers. You can see the ethnic mix of the participants there on the screen. Most of them were white parents. There was one Black British member. They were mostly well-educated parents. 4 of them had master's degrees. The parents were a median age of 34 years, and their child was a median age of 8 months. 5 of the children were born at term and 4 were preterm, and most of them had been diagnosed by 4 weeks of age. So after doing the full thematic analysis, as I had described earlier, we were able to find 4 themes in which the parents' experiences could be categorized. The first was the impact of gastro-oesophageal reflux on family life. The second was the challenges in the management of gastro-oesophageal reflux, then the role of healthcare professionals, and the need for information and education. I'll take you through each of these themes and the sub-themes that were related to them now, along with some key quotes from the parents. The results from qualitative study, the main results from qualitative study are word by word what the parents tell us. So I've tried to reproduce as much of the quotes as possible on these slides, but I will not read them all out to you because it'll just take time. The paper should be out very soon, and I'm happy to share the slides later. So the first theme was the impact of gastro-oesophageal reflux or reflux disease on aspects of family life. And in that, we identified the sub-theme of impact on activities of daily living, mental health, and the role of support. The parents were very clear about the challenges to day-to-day life, such as even simple things like going to the toilet, leaving the house, seeing family and friends, and the fact that they were completely unable to manage other tasks, even mundane household tasks, because of a baby who was so upset and crying all the time because of, in their view, gastro-oesophageal reflux. And they had a feeling of helplessness and self-blame. The quote here talks about are words of a mother who felt that she wasn't even able to go to the bathroom, especially when her husband was at work and she was on her own at home. They talked a lot about impact on mental health and well-being, particularly from the helplessness and self-blame, and talked about how support from spouse and other parents who were going through the same thing was something that helped them cope better. This parent here is talking about, has told us that if it was not for her partner's strength, this illness would have tortured her mentally. But because she felt that her partner was very strong and was able to support her, she was able to cope with this a lot more. Then the other sub-theme on the impact on family life was the parents' perception that their reality of parenting did not match their expectations at all. These parents said that they were not prepared for a baby who would be crying all the time. Nobody had told them about a condition that on one hand they would be told was harmless, but on the other would be a constant problem for them and their child. And this was reported more by most mothers said, the 8 mothers who were interviewed, most of them said that they felt that this effect on parenting experience was more for them than for the fathers. One of them saying that she felt that the husband had found it really difficult and found that the father was unable to bond with the baby because every time he was with the baby was crying. This particular sub-theme that came out of it, impact on infant feeding choices, I think everyone in this forum will recognize has very important implications for our practice. Parents reported that they thought that breastfeeding was very difficult for a baby with reflux, particularly when it came to treatment. They felt that all the treatments had to be put into expressed milk, and that meant that there was a layer of complexity added to breastfeeding, again, something that they were not prepared for. And some of them, unfortunately, reported that it affected their decision about feeding the subsequent babies. The quote here from a mother is that she did not breastfeed her second baby because it had not been a pleasant experience all around at all for her with her first baby who had gastro-oesophageal reflux in terms of giving Gaviscon, and therefore she decided not to breastfeed the second baby. It was a real nightmare, is what she told us. The second theme, the challenge, is in the management of gastro-oesophageal reflux. Parents talked a lot about struggles with different medications. They felt that giving the medication was time-consuming. At no point, most of them did not feel that whether the medication helped or not. Some even felt that it worsened the situation. Those who had used Gaviscon particularly complained of constipation. And then there was the added complexity of difficulty with accessing suitable formulations. The quote here is from a mother who was unable to get omeprazole capsules. Capsules had been prescribed and the pharmacy refused to give it to me, she says, because they've said you can't give a capsule to a 1-year-old baby. And then she also felt she felt that the pharmacists were not feeling comfortable giving it to a baby, despite the fact that the pediatrician had prescribed it. And this whole experience was very, very frustrating for the parent. In this theme, the sub-theme, the second sub-theme was importance of managing expectations. Parents talked about how the importance of understanding the treatment options, understanding that treatment options are not necessarily a cure, and the knowledge that gastroesophageal reflux in most babies will not last forever may have been very helpful for them. The parent here tells us that the most helpful thing for me was that the consultant being really honest about how to manage our expectations. And she says that he was just quite honest and said, you know, he has a refluxy baby, he will grow out of it, but the next few months are going to be really tough until he does. I think Mark alluded to this in his talk previously, is where we need to tell parents that baby's reflux, this may be normal, and to reassure them that the baby will get better, but also to acknowledge that this difficult time is really difficult, and that what the parents are feeling should not be negated. Yeah, there we are. And then moving on, the next sub-theme was importance of the attitude of healthcare professionals, which really follows on nicely from the previous quote. The parents felt that there were varied encounters with a number of healthcare professionals who ranged from being patronizing and dismissive, which parents felt led to delays in diagnosis or inappropriate management, to those who were very understanding. And some parents felt that they were shown understanding, and in particular, the mothers and the father that we interviewed had very good things to say about health visitors. The quote here is that the parent felt that they were overlooked by a lot of health professionals at the beginning, just kind of saying babies will be babies, babies cry, babies scream, babies arch their backs, and a lot. The parent felt that a lot of the real symptoms were overlooked just because we write off signs and symptoms in babies as just things babies do. The next theme was the role of healthcare professionals in the diagnosis and management. And in this, it was very interesting to see that the parents felt that because of the lack of help that they were getting, they almost became healthcare professionals for their babies themselves. So they found that they reported that they felt that their role of parent was overlapping with that being a healthcare professional for their own baby. And they had to drive care and become experts with a lot of online reading and getting advice from other parents rather than from doctors and health visitors. Of course, you will remember from when I described the 9 parents that we interviewed, this was a self-selected group of highly educated parents, and hence there was a lot more, which is not necessarily a bad thing, a lot more drive from the parents to find the answers themselves if we were not giving it to them. And this mother reported that she did independent research because the GPs were lovely and helpful, but she was just not satisfied. So she says, okay, what she felt was the advice she was being given was, okay, here, put them on some medication, because medications help the symptoms and it helps to relieve the problems at the time. But long term, what is going to happen? So she was prompted to look into more information about reflux as a whole and find it for herself. They also reported about lack of continuity in care and lack of continuity in care, and the quote here is wrong. Lack of continuity in care. I apologize for that. The quote has not come on the slide here, but this was about they felt that they were being handed over from one healthcare professional to another, with the GP saying that they need to see a pediatrician. The GP can't help them because it's a baby and they're not experts of babies, while the pediatrician's not giving them an appointment because it's a relatively straightforward problem and the GP should deal with it. So there was a lot of talk about rejected referrals to pediatricians. And then finally, the theme of more information and education on symptoms of gastro-oesophageal reflux, both for clinicians and healthcare professionals. First, they talked about education for clinicians, and parents felt that healthcare professionals should have more training on.
Hi, how are you doing?
Infant and gastro.
You're unknown by the phone.
Sorry.
How are you?
Sorry, I'm not sure, but there was someone saying something. I don't know if that was a question.
There's somebody not on mute, I think, on the phone.
We're just working on muting everyone. Apologies.
Thank you.
An online meeting. Let me just turn it down a bit.
So I'll carry on if that's okay. So yes, this was the theme was about need for more information and education on the symptoms of and management of gastro-oesophageal reflux. And for clinicians, the parents felt that healthcare professionals need to have more training about the condition, but also more training about how to communicate with parents about the condition, and that there should be more evidence information available for evidence-based management, which is exactly what Mark and the rest of us are trying to do with the study that with the Otter study. So let's hope it gets funded. Parents talked about better definition of gastro-esophageal reflux, and here is a quote from a parent who says that maybe for healthcare professionals as well as for parents to say, like, this is a normal amount of regurgitation and this isn't a regurgitation that needs attention or is troublesome. So trying to understand the difference between reflux and reflux disease. Along with the clinicians, the parents also felt that there should be more education for parents and parents-to-be. This links with the previous sub-theme of managing expectations. Parents reported that they feel that the condition is very misunderstood and that the impact is not talked about. There is very little awareness of the impact of the condition, particularly on family life. And the quote here is that perhaps sensitizing people on reflux, like even before they get children, putting in posters, hospitals, maternity wards and maternity areas, and maybe using newspapers and social media to sensitize people, because I realized that I wasn't the only one who didn't know about it. So with all that information, quite a lot of information from the parents, quite a lot of listening to them and systematically organizing what we were hearing, led us to a good understanding, to realize that parents, after they've had the experience of a baby with gastro-esophageal reflux, have a good understanding and knowledge of the condition, but that this is a condition that affects all aspects of family life and the whole parenting experience, that there's some very serious impact on mental health, important impact on not just the health of this particular baby, but the babies that these parents may go on to have in the future, particularly in terms of feeding and nursing choices. Parents had a mixed experience of medical management with a lack of consistency in care received, and they highlighted the need for more information and education, both for themselves, but also for healthcare professionals. Just to highlight that this was a very robust qualitative method study. The sample size appears to very small to those of us who are used to working in numbers, but this is actually quite a decent sample size for a qualitative study. And the in-depth exploration and the robust methodology of triangulation and double coding really makes the results quite valid. However, we acknowledge that the sample size remains small and there may have been a selection bias. It's a selection bias that I'm more concerned about. We recruited through social media channels, which itself puts in a bit of selection bias. However, data saturation was reached on most points. So, and the other limitation was that we were able to speak to only one father. A larger study should include more fathers and hear more from wider family members. The parents that we interviewed, again, probably because of the self-selection for participation, most of them had felt that they had children with gastro-esophageal reflux disease rather than gastro-esophageal reflux, although none of them had received treatment more than Gaviscon or anti-reflux medications. So with that, we concluded from this study that there is a need for more conversation and more ongoing input from parents, both as part of clinical care, but also to drive research, such as the Otter study, and that all of us, both parents and healthcare professionals, need more training and evidence for management of babies with gastro-esophageal reflux disease. That's what I had to say, and I think I should be able to stop sharing now.
Thanks, Shalini. That was fantastic, and well done distilling such a huge amount of work into a relatively short space of time, because they're not easy to do, those kind of studies. So that was really fascinating. We'll do questions in a panel bit at the end if you're happy to stay.
Absolutely.
And in which case I will move on to Dr. Janet Berrington. who is going to give us an overview of the rather extensive and impressive pack of work in NEC that goes on in Newcastle. Thank you very much, Janet.
Sorry, can you see my screen? I realized I was talking and muted.
We can
you see it?
I can see half of your PowerPoint program as opposed to a presentation, and I can see your like window screen.
Sorry.
That's it?
Yeah.
That's good.
Can you see the full slide as opposed to the speaker view?
No, that's the whole. I can see it. As long as it ends with the Stewart Lab in the top left.
It does end with the Stewart Lab. Yes, brilliant. Okay, so thank you very much. Oh, I think it's on autoplay as well, which is always a worry, isn't it? So I'm going to speak, as Mark said, about the neck research in Newcastle. It is going to be a whistle-stop tour, so big overview, not a lot of detail about anything. And just before I go any further, just want to acknowledge that both a lot of the work that's presented is contributed to by many people, and also some of the slides have also been written by other people, so not on any level all my own work. So just as a wee reminder, I know that we're speaking to an audience who are interested in this, but neck remains a big problem for neonatologists. And these are just some data that I've extracted both from NNAP and from Cheryl's paper looking at severe neck, so surgical or neck causing death. And you can see that around 400 infants a year are affected in the UK, and around 200 of those infants, unfortunately, will die, not necessarily from their neck, but having had neck. So it's a big problem for us. And in terms of progress, in terms of making prevention better or having good treatments, we haven't really achieved anything. So we don't really have good treatments, and we don't have an ability to prevent neck, although clearly probiotics may be influencing some cases. What we think we understand is that neck is probably contributed to, for many cases, but not all, between an interaction between the gut microbes, the nutrients that we offer the baby, and then the host immune response to those two things interacting. And that is where the Newcastle research team have some focus, not all their focus, but some of their focus. So we're really lucky here. We have this great collaboration between a team of scientists and a clinical team. And we describe that collaboration as N4, given that N3 already existed. So that's the Newcastle Neonatal Nutrition and Neck Research. And the two key bits of that are the biobank and Chris Stewart's laboratory, where most of the science that we undertake is actually done, although we do have collaborators across the world. So the way that that works is that we approach parents of all of our babies, of infants who are sub 32 weeks. And because we've been doing this for a very long time, that now encompasses more than 1,000 babies and many, many thousands of samples. So if anybody's listening and thinks they want some, please take them off my hands. And then we're collecting a combination of things that we view as otherwise waste products. So we salvage milk from the ends of feeding tubes and syringes and bottles. We salvage stool from the nappy. We salvage urine from the nappy. And if a baby needs to go to theatre, we ask for permission to salvage some of the already resected tissue. And whenever a blood sample is sent to our laboratory, we ask for access to any residual blood. And then, as you can see, we can use those samples to do a variety of now sort of pretty standard techniques to explore various translational aspects of why some babies get neck and other babies don't. So those samples hop into our bank. And we're exploring, for the purposes of this talk, neck, but we have obviously got interest in other things. So can do the same thing in terms of how you use your samples to explore pretty much any disease that we might want to. But also really important for us is that we have this large healthy cohort of babies. So we have something to compare our diseased babies to. And what we're looking for are mechanisms of disease, so we can try and unpick them and understand them, and drivers of disease. And again, I know that I'm talking to an audience that's aware of all of this, but the gut microbiome is particularly important for infant health. It's got many, many different roles as outlined on this slide. And in preterm babies, particularly important for maintaining health, but the microbiome in the gut does not work in isolation. So as I alluded to earlier, we're also really interested in the nutrients and how they impact on neck, and also the hosts of the immune system. And that is what the basis of our translational work is looking at. So in term babies, this is Chris Stewart's work. In term babies, we know that breast milk is the major driving force behind the gut microbiome and its development. So if you're a term baby, whether you're getting your mum's own breast milk is the single most important thing, really, really important. However, in preterm babies, we know that that isn't really the same. And that is because those preterm babies don't have normal exposures to the things that a term baby does. So we refer to the preterm microbiome as dysbiotic in comparison to the term microbiome. And when you think about all the things we do, so our modes of delivery, our antibiotic exposure, the feeding practices, all of those lovely drugs that Shalini was talking about, it's not difficult to understand why that microbiome might look very different. So this is the interaction that we're attempting to unpick and the key diseases. But as I say, for the focus of this talk, I'm going to talk about NEC particularly. And the two parts where we've got most data, most information relate to the microbes and also the nutrients. And that's because they're very attractive for us as clinicians as being modifiable, much, much more difficult for us to modify the host response. But we do also have some data and some thinking around the host response as well. So there are also key sites for us to think about. And in terms of necrotizing enterocolitis, the key sites for us are the breast milk, so the maternal breast, and the infant gut. I looked for a map that would show Newcastle as the centre of the world in order for me then to show you how widespread our collaborators are. I don't understand why, but that map doesn't exist. I might have to draw it myself. So this map is the alcohol use per capita. So not Newcastle as the centre of the world, thank goodness. So we have these collaborators who are now spread across the world who help us to do specific things that we ourselves don't have the capacity to do, which doesn't include drinking alcohol, unfortunately. So one of the key things for any of the translational work is being pretty certain that if you're going to pull a sample from a baby and call that a sample that relates to NEC, the baby actually really had NEC. So underpinning all of our translational work is this worry and anxiety about which of our babies really has got NEC. And some of you will have read some of our publications trying to firm up that, and some of you may have heard some of us talk about this, but it's one of the key factors for this whole series of work. So who's actually got NEC? So our approach to it is one, first of all, of consistency. So if any baby who comes out of any Newcastle study is labelled as NEC, that will have been through the same clinicians coding that baby. And we review in a very painful manner all information relating to that baby. So every piece of clinical information, radiological, laboratory, surgical, and histological, if it's available. And again, some of you will know how big a problem we view focal perforation or spontaneous perforation as in terms of contamination of data sets, both in clinical studies and in translational work for NEC. So we've then gone on to publish our relatively large cohort, not large in comparison to VON, but very detailed cohort of NEC babies, and to try and demonstrate some of those difficulties and also describe well the cohort that we're referring to in our translational work. So this is a paper in Archives that's trying to help people to be sure that in their own work, they exclude babies with focal perforation and looking at how that can be best achieved. This similarly looks at the impact of timing and whether that makes us believe that there are different types of NEC, so early or late onset NEC, and whether or not we can use timing to separate focal perforation from necrotizing enterocolitis. And then we've also published data looking at the impacts of some specific things. So this one is the impact of transfer, so not being born in a surgical centre in the northeast, but having to be transferred for NEC surgery. And here you can see that in the north, at least, of England, if you need transfer, it increases your risk of both all-cause mortality and NEC-related mortality. And then similarly, we've been able to look at the impact of using probiotics in our own unit. And unlike some other studies, we did not see a response to the probiotics that we were using at the time. So that was Influran and LB2. That is not to say that probiotics in general are not a good thing. So we've got that other part of our work going on. And as I say, I think it's a reassurance. I hope it's a reassurance. If we say a baby has NEC, then it did have NEC. So we are also exploring whether we might find slightly different categories using AI. So this machine learning is underway in our own cohorts. So on the left, you can see the 3 types of disease that we would classify these babies as having, so medical NEC, surgical NEC, and focal perforation. And on the right, you can see that if you use a machine learning model, we actually see 8 different patterns of disease. So perhaps there's some different classifications that we will move on to, and that might teach us something slightly different in both the translational and epidemiological work. So this is what that data looks like if you look at the subgroups, so that you can see that most of my subgroups, there are actually 2 subgroups of disease in, and then there's a group of babies that we have labeled as NEC, which perhaps machine learning would say is not actually necrotizing enterocolitis. So what about the mechanistic work? So as I say, this is the model that we use. So having a deep detail about the baby's clinical course, we're then able to select samples out and explore specific aspects of translational medicine. So we're going to think about what we've learned about the microbes and their role in necrotizing enterocolitis first. So this was our first series of data where, using 16S, we looked at a large number of infants who were either healthy or had necrotizing enterocolitis. And I think you'll be pretty convinced that all of these patterns, so these are patterns of disease, patterns of microbes in babies who are either healthy or diseased. I think you'll see that these are actually pretty random, and there's very little ability for me to say to you, aha, over here is a NEC pattern. So pretty much we saw chaos in our babies as an initial look. However, we did see some signals. So we did see a reduction in diversity, so how many different types of bacteria babies were hosting in necrotizing enterocolitis, so they're the green babies, in comparison to either control babies, so healthy, or those who develop sepsis. And we also saw recovery after disease for all babies post-discharge back to a same endpoint. So it doesn't matter if you were diseased or not, after discharge, your microbiome is seen to recover. There is some animal work that suggested that the total bacterial load perhaps contributes to the development of NEC. So babies developing disease carry more bacteria than babies who remain healthy. So again, same methodology, we're able to pull a subset of samples of stool from babies who have or who don't have NEC and look at the total bacterial load. So the pink part of the graph is showing you the bacterial load before disease onset. So disease onset occurs here at time 0, 2 days before, 1 day before, and then after. And what you can see is that there is no difference in the bacterial load before disease. After development of disease, the bacterial load goes down in NEC, but of course, we're then treating these babies with antibiotics. So I'm going to move on to talk about the role of the preterm gut community type and how we use that to perform some slightly more complex analyses. So this is just a demonstration of how that works. So here you can see a whole lot of babies' data, and then all of the bacteria that the babies are carrying. And then we ask a machine to code those babies into groups. So these babies are most common to each other. These babies are most like each other. And so then we have these preterm gut community types emerging. So this particular one here groups into 6 subtypes. The first one of them is dominated by Klebsiella. The second one has Klebsiella and Enterococcus faecalis. And you get the idea that these different types of dominating bacteria allow us to classify our community types. So this particular study is looking at NEC with some matched controls. So these are big numbers of stools, but smallish numbers of NEC. The numbers get higher as we go through our data. And then what you can see is that if you watch individual babies and you look at how they move for community types, you can start and see differences emerge. Let me just see if I can get that video back for you. So you can see a baby move over time here. So this red baby has NEC. And what you see is it's moving from community type to community type. So it's touching base with almost all of the different colors, which represent the different community types. But we've got a green baby in the middle who stays a healthy baby. And it starts off in the community type 6, or the yellow community type, and it stays there. It never moves. So it always has this most healthy community type, and it never budges from it. So when you take all of that community data, you can see, you can present that graphically in ways like this. So here's that healthy bifidobacterial rich community here. And you can see that babies who hold that community type almost never progress to NEC. So if you don't get NEC, you're most green. And if you do develop NEC, you're most purple. So you can see this lovely bright green for this community type 6 in comparison to, for instance, community type 2, which is much more likely to progress into necrotizing enterocolitis. So we can see differences in the types of bacteria the babies are hosting and how they move from community type to community type. But presence of bacteria is not the only important thing. So we're also really interested in their functionality. So we can then look at the metabolites produced by that stool, and we could do a very similar thing. So we can look at time points when NEC occurs, and then we can say, are metabolites different in healthy or diseased babies when their time point matched? And for these key metabolites here, you can see in red that the babies with NEC have a very different metabolic expression than the healthy babies in blue. So that again might help us to learn about what's actually changing from a functional point of view in the baby's gut. So that's some clues to the disease process, but we're also, as I said, very interested in healthy babies and what it is that keeps healthy babies healthy, and whether we might be able to drive babies to remain in a healthy gut community type. So these studies are getting bigger as time goes by because we're accumulating more and more babies. So this is 123 babies and 1,400 stools. That is a lot of baby poo. Using the same type of principles, we can look at the stools and we can classify them into groups, and then we can say, of the variables that we know those babies are exposed to, what is it that is most influential? So we know these are all healthy. What is it that's impacting on the gut microbiome, and hopefully what is it that's maintaining health? So here you can see time points moving across the bottom. So youngest time points, so first week of life, moving towards our later time points. The size of the blob tells you how big the impact is, and then those that actually reach statistical significance have got a red box around them. So this is looking just at healthy babies and at taxonomy, so which bacteria are present, nothing functional at the moment. And you can see that in Newcastle babies, so this is all Newcastle babies, the biggest influencer of the healthy microbiome is receipt of probiotics. And then second to that is receipt of breast milk fortifier, which can only happen, of course, if you are receiving maternal milk, or at least could in this cohort because we didn't have donor milk at this point. And we can see the same thing emerge if we look at the functional metagenome. So what are the bacteria actually doing? So we see that the most influential thing in the Newcastle babies is receipt of probiotics. So this is a little bit of helpful data to suggest that receiving probiotics is actually doing something, both in terms of presence of bacteria and function of bacteria. So that's all in Newcastle. But we know that in Newcastle we give probiotics. We know that babies are very influenced by the other things around them, and that the environment they're in drives the gut microbiome quite a lot. So we were able to do some mechanistic work embedded in the Dolfin trial, which was the randomised controlled trial of enteral lactoferrin, the aim of which was to try and reduce late onset sepsis. So that allowed us access to inference from 13 UK centres. So really nice big numbers of babies now, really big numbers of stools, and also some urine metabolomic work that we were able to undertake. And what you see now when you've got different sites is that for these different measures of impacts of various factors, so here's lactoferrin, which was the trial intervention, but also gestation, feed type, number of days of exposure to your lactoferrin, and here, importantly, the site that the baby was in, and the impact that each of those things has on the bacterial profile, on the volatile organic compounds in the stool, on other stool metabolites, on the urinary metabolites. And what you see really emerging very nicely from this data is that the single most important driver of the gut microbiome in the baby is actually the site that the baby is in. So very, very important when we then start and look at the literature on particularly NEC and what it is that's changing in the microbiome. We need to be very thoughtful of the fact that where the baby is a key thing. And this data started to bring together some of these key aspects and look at multiple aspects in one study. So this is moving on to dysbiosis in NEC. So we know if we look at the literature that babies have different microbiomes in necrotizing enterocolitis, but depending on where the study is, i.e. which units those babies are in, they are different from study to study. So these are our Newcastle healthy babies. And we have in this particular study 5 of those preterm gut community types that I explained to you before. And what you can see here emerging is the idea that we've got 2 different community types, which are those healthy community types, so bifidobacterial rich. And here we're exploring the impact of receipt of probiotics on transitioning to those more healthy community types. So fortunately, because of the way we introduce probiotics, we have a cohort that never received probiotics. We then have a cohort that received Influran, and we then have a cohort that received Labinic. And I think you can see relatively convincingly that as the babies move from their earliest stool sample to their latest, where there are no probiotics, we find it difficult to push babies into that healthy bifidobacterial-rich community type. Influran does it really beautifully. Labinic does it a little bit, but doesn't do it quite so well as Influran. So we can see here how probiotics might be exerting their effects. We can also see the impact of these other things that we've alluded to previously. So receipt of mums on milk, which we would expect, and antibiotics also impacting the healthy microbiome. We can look at persistence, so we can look at the latest stool we have after we've stopped giving our probiotics, and we can see that it's different. So Influran persists slightly differently than Labinic. So even the same type of bifido persists differently dependent on the actual probiotic that was given to the babies. And again, kind of proof of principle, we can show that the stool metabolome, so what is it those bacteria are actually doing, is really different across those 5 community types. And in actual fact, so is the serum metabolome. So proof that the gut microbiota is having some impact directly on the host, which is really nice to see. And I'll explain a wee bit more about the enteroids in a minute, but we've got a preterm enteroid model, so resected gut, that we use to then grow little mini guts, and we can do some very lab-based work. And here you see the impact on that enteroid of putting on the community type of each different stool, and you get very different gene expression. So again, proof that the bacteria are impacting host functionality. Some of our collaborators do very different things than us. So this is Lucy Crouch, who works in Birmingham, who looks at the glycans in infants, well, lots of different things, but here she's looked at the role of the bacteria who produce glycanases in breaking down mucin, and some neck tissue in comparison to adult UC tissue or colonic CA. And what you can see is that the actual O-glycans are quite different, and the bacteria then that can break them down are quite different. So for us, in terms of thinking about the original breach of the mucin layer, that might be really important mechanistically. So just a summary then about what we've shown in terms of the gut bacteria. So they're key to baby health. They're different in health compared to disease. They're different in neck depending on where you are, and they're different in different units. And I ran out of difference at that point. Site has a very big impact and bigger impact than health, and function is also different in neck. We can demonstrate that probiotics drive infants to this mature PGCT, and that different stool bacteria and host function can be shown with probiotic receipt. And we can also show that the community type changes an organoid genetic function, so expectation that would do the same in the human host. So moving on to the role of nutrients. So it's the second more easy part for us to look at. So I think, again, everybody that I'm talking to will know the importance of human milk to human babies and the benefits that's been shown to receiving your own mother's milk. So this is Dolfin study showing that if you get more than half of your own mother's milk, you're much more likely to survive free of either sepsis or necrotizing enterocolitis. But the question for us is, what is it? What is it that's driving that process? So again, we're able to take milk and stool and try and answer some of these questions. So human milk oligosaccharides, they're sugars that are in breast milk that feed bacteria rather than babies, and potentially might help babies to remain healthy either by impacting the bacteria, preventing some of the bacteria becoming actually pathogenic, or potentially having a direct immunogenic effect on the host. So this is somebody else's data, not ours, but data that suggested that one specific human milk oligosaccharide, so this thing here, DSLNT, is different in milk of infants who do not get necrotizing enterolitis compared to those who do. So lower levels in those who went on to get NEC. This is quite a small study, so 8 infants with NEC. So again, we're able to just go to our freezers and pull some breast milk and see if we also see the same thing. So these are 33 Newcastle babies matched to controls. These are all of the HMOs that we were able to measure. And up here, you can see DSLNT is the only one that's significantly different in infants who have NEC compared to those who don't. So when you actually analyze how different they are, these are our NEC babies, these are our healthy babies, you can see that there's quite a significant difference, and we're able to come up with this threshold value here of just over 240. We can then look at the impact of that DSLNT level on the bacteria. So linking the sort of nutritional element to the bacterial element, and we can look at ability to progress to those healthy PGCTs if you have a DSLNT level that's above the NEC threshold from our data or below. And again, I think it's moderately convincing that if you've got good levels of DSLNT, you are much better able to progress to these healthy gut types. So moving tack slightly, this is Claire Granger's work, which looked at maternal IgA. So there is data already in the public domain suggesting that the amount of IgA in your mother's milk might be protective against NEC, and that it may work by binding bacteria in the stool. So we've been able to explore that a little bit further. So our first task, or Claire's first task, was to look at how our normal handling processes impact on the levels of immunoglobulin in breast milk. So this is milk taken either fresh and analysed into a fridge, frozen, or then passed through our plastic syringe and tubing. And what you can see is that those processes don't really impact on IgM or IgG, but they do really impact on both total IgA and secretory IgA. So the message here for you all is optimize fresh milk wherever possible, and that means don't even pop it in the fridge for a few minutes if you can manage it. We're also able to look at when the babies first start to produce their own IgA, so that what I've just shown you was IgA in breast milk, but babies will start to produce their own. So in order to do that, you need some exclusively formula-fed babies. So you'll be glad to know that we don't have very many of those, but we had enough to let us look at them. So they don't start to produce their own endogenous IgA until after their 3rd week of life, whereas the breastfed babies here have IgA in their stool because it's in their mother's milk. And we're also able to look at babies who remain healthy and babies who go on to develop NEC, and whether they're exposed to different levels of IgA in their mother's milk. So here are healthy babies in black, nice high levels of maternal IgA, both total and secretory, and our NEC babies in red, who are exposed to lower levels of IgA in their mother's milk. So our median onset of NEC is just here at the point where the endogenous production starts, which would then make sense from a mechanistic point of view. We've also been able to look at the impact of an exclusive human milk diet on the microbiome. So this is the Indigo data. This is Tom Sproat's work. So in a randomized controlled trial, babies were exposed to either an exclusive human diet, this is using the prolacta fortifier, so a liquid one, or exclusive, as much human milk as there was available, and then formula for shortfall and a bovine fortifier. And then within that, we're able to look at the impact of trial arms. So did you get exclusive human milk or not, which is this little pink arrow here, and various time points through the baby's life. And what you can see is that the impact of that overall on the microbiome is really very small. And as seen with other data, the center and probiotic receipt dominate. So we have a little bit of data suggesting that you can restore donor milk microbiome by mixing it with maternal milk microbiome. So we've been able to look at the impact of maternal milk microbiome on baby microbiome. That data isn't quite published, but it will be soon, and we see very minimal impact of the maternal milk microbiome on the baby's gut microbiome. So there are some other drivers of microbiome change, so things that impact on the bacteria, as well as all the things we've talked about. So phages or phages, which are the viruses that infect bacteria. So this work's taken part in Northumbria. So we've been able to extract what we think is a core phage community from breast milk over the first few weeks. And again, as you might expect, it's dominated by phages that infect skin commensal bacteria. And we've also been able to look at NEC babies' stool compared to healthy babies' stool. And what you can see is a difference. So these babies have got NEC, these babies are healthy. The difference in how that viral phage characteristics change over time. So in healthy babies, the phages start relatively high, drop and then get higher. And in NEC babies, we have this early increase, but then a fall off of the phages. So potentially mechanistic in terms of driving the gut microbiome. So just a quick milk summary. So we think DSLNT might be important. We know that the IgA differs in maternal milk. If you're healthy or go on to get NEC, please give fresh mum's own milk wherever you can. We know that babies won't produce their own endogenous stool IgA until they're about 3 weeks old. And we don't think that just an exclusive human milk diet on its own has a big impact on the microbiome. And we do think that the phage profiles differ in health as opposed to in NEC. So finally, I'm going to talk a little bit about the organoid model. So our infants who need surgery, we have permission to access the resected margin. So we have relatively healthy tissue. It's now a very standard part of an infant going to surgery. So almost always now get tissue back. So therefore we have more than 70 preterm enteroids, and those enteroids are reflective of the infants from whom we took them from. So from 23 weeks onward, and from diseases like NEC and focal perforation, some reversal. So we have some more mature tissue and an occasional atresia. So what happens is we give the tissue to the lab and they resect the crypts where the stem cells are. They're then able to grow a little mini enteroid, and they've got a model which allows both an anaerobic and an aerobic element, simulating obviously the gut structure in real life. So we can then look at the impact of various practices. So we can put human milk or LPS or other things onto our enteroids. We know that the preterm enteroids behave really differently than the adult model. So this is response of the preterm and the term enteroids to bacterial provocation. And we know that many, many different genes are differentially expressed. So if you want to do that sort of work, use a preterm enteroid. And as I said before, we know that the enteroids change their gene expression dependent on the gut community that they're exposed to. So just in summary, NEC's a really complex disease, really difficult for us to all agree who actually has it in the first place. The salvaging does allow us and has allowed us to do what I hope is going to become useful translational work for the babies, looking at microbiome, nutrients, and the host. The host is the most difficult. We can only do this with the help of our parents, and as I say, we're really lucky in Newcastle. We've got this great collaboration between the scientists and the clinicians, and worldwide collaborations. So thank you to all of those, and I'm going to stop there. Thank you.
Thanks very much, Janet. That was an amazing amount of stuff. Very impressive. We've already got some questions in the chat about all the talks. I might start with one of the ones for you because it's literally right in front of my face. So it's Raoul has asked, with regard to site and NEC, do you mean level 3 and level 2 units? I presume it means the difference between the where you're seeing the difference is the level of unit or just the actual site. No,
it's the actual place. So we had 13 different units, and they're geographically quite widely spread across the UK. So all of the magpie, all of the elfin sites were magpie sites. So 13 sites that were taking part in the lactoferrin trial also contributed samples to our study. So it means that we've got samples from different units, because otherwise what we see is true in Newcastle, but it may well not be true in other places. So it really helps us to unpick what the drivers of that microbiome are. Does that make sense?
Mm-hmm.
Yeah.
His follow-up, his other question was, can you add DSLNT to milk?
Not yet.
Not yet.
Not yet. It's really difficult to make, but it's not impossible. Very, very expensive currently. Yeah, not yet. If you could, we would try it.
And the other question is, do you have any data on the impact of proprams on microbiome? Obviously,
not yet.
Infrared labyrinth, but you're using proprams now.
We are, yes. So we will have very soon, but not yet.
Oh, and finally, which would be your probiotic of choice? Imogen's just asked.
Am I allowed to say it? So we moved to proprams for very good reasons. Yeah.
Proprams, I think, is the only one that meets the ESPGHAN recommendations in full, isn't it? Is that right? I think
there are good. Yeah, there are good reasons to currently to favour proprams.
There's a few other questions. I did answer one in the chat, but I said I'd talk about it a bit more. So I had a few questions about my talk, and I think I was going to answer in the chat, but essentially, the stuff I presented was largely from the NICE guideline, and I wasn't necessarily endorsing the use of feed thickeners and things like about in preterm mid babies, because I would agree that the evidence it's a bit more worrying in that group. So that's NICE recommend that for all. It's a sort of blanket infant and child advice, and I would be more cautious in preterm infants in terms of how you manage reflux. Because I think Gaviscon's okay, and I think there's a little bit of evidence of that I think I showed, but the other stuff is a little bit less clear. I wouldn't necessarily go to anti-reflux formula, for instance, in a preterm infant. Sometimes I have in the past, for particularly well-grown ones that are well past their due date, where we've tried other stuff and it's not worked. But obviously, if you do that, they can't have their preterm formula, so that's a problem. There was a follow-up question. Someone said, what would I put in a guideline? And this might be one for Charlie as well. What would you put in a guideline for reflux in preterms? And what investigations and management of what would you do for reflux in preterm infants on the NICU? And my initial reaction to that is I'm not sure I'd want to write that guideline. Particularly, I'd want to shy away from investigating these children, because I think, as I said, a lot of reflux in preterm babies is normal. And also differentiating reflux from preterm baby apneas, bradycardia, and prematurity is tricky. And I think you'd get yourself tied up in quite a lot of knots if you did that. I think having a sort of guideline with some stepwise management to what you do when you are clinically confident it's reflux is perhaps useful. And the problem with that is I don't think we know what we would put in it because of a lack of evidence, which is partly why I've included preterm infants as a separate group in the proposed trial I talked about at the end. What other questions are there? And please stick your hand up or put something in the chat if you've got any other questions. The final thing that came up in the chat was about what is the role of propping babies up and positioning and stuff like that. And that's a really good question. And I'm not sure what the evidence for that is. It clearly makes a lot of sense from a physics point of view. And I think NICE do endorse things like holding the baby upright after a feed, particularly term babies, before you lay them down immediately. In terms of how you position them at night, that's tricky, as lots of people allude to in the chat, because obviously we want to put them flat on their back to sleep. That's the safe sleeping advice, and there's nothing in there about what angle that's at and what a safe angle of incline might be. So it's a slightly trickier area, and I don't know what the evidence for those things are in terms of A, whether they work. It makes sense from a physics point of view that it might help, but B, whether it's safe, whether different angles of sleep impact on the risk of cot death, I don't know. So I can't answer that one, but it's a good point and certainly worth thinking about. But I guess with all things, there's always going to be a balance of risk and benefit. But yeah, tricky to come down clearly on that, and a hard thing to advise parents on, I think. Pratim has just put in the chat, in practice, I've seen clinicians choosing PPI over Gaviscon for small preterm infants. What is my opinion on it? I guess other people might have a view. So Charlie, feel free to say what you think. Because we don't have any evidence for it, and because there are definitely documented risks, I'm not keen. Unless we're really desperate. I think I might have done it in the past, but I would reserve it for those babies where it's really severe and where they are more like term babies because you're having problems because they can't get them home because of ABCs or because of difficult reflux. I think that in that situation, you could argue that the potential benefits might outweigh the potential risks, but certainly while they're still quite prevalent still on the unit, I would try and avoid it. But not all my colleagues feel the same. There's definitely a few babies on our unit at any given time that are on it, and I'm not going to go around stopping it because there's we don't know either way whether it works or not. So it comes down to personal preference. Oh, someone said, do you think it's Will Williams says, do you think it's necessary to prescribe PPIs concurrently with steroids for gastro-perfection? I don't, again, know the evidence that. My personal preference would be to give them a bit of milk for gastric protection. I think there's same goes for ibuprofen. I think there are some places that give ibuprofen PDAs and give omeprazole as gastric protection from the ibuprofen. But again, because of those risks, particularly in preterm babies where they're still actually prem, as in well below 28 weeks, I think the risks outweigh the benefits and would go for milk as a gastric protection for those children. There's similar academic effects of PPIs in surgical patients and risk, says Tom Wiley. That is true. And actually, a lot of the stuff I said applies to your kind of common or standard baby. I think for those with neurological problems and things like that, I think there are different kettle of fish, and they get prescribed a lot of these medicines, and lots of people argue that they're essential for that group of patients. I'm not sure what the evidence is, but there's certainly a lot of people who feel they are appropriate. Interestingly, in terms of surgical patients, one of my colleagues, Nigel Hall, is doing a trial, just starting to get a trial off the ground at the moment, that's being funded, looking at the use of PPIs in infants with esophageal atresia, post-esophageal atresia surgery. So that might help provide a bit of evidence for that group of patients. Sean, I don't know if you want to comment on any of the things I've just randomly made up about reflux, and whether you, are you a PPI person on your unit?
No, I am not at all, Mark, but we do always tend to agree in N3 groups. It is a group of like-minded people, but despite that, I will say that I'm entirely in agreement with you about not using PPIs in preterm infants. And for me, if I had to, gun on my forehead, had to write a guideline about management of preterm gastro-oesophageal reflux, I'd more focus it on what not to do than what to do. And one of the things not to do would be to prescribe unnecessarily antacid medications, both PPIs as well as H2RAs, definitely not, because there is no evidence of them being of any benefit, and there is evidence of their being potentially harmful. I just wanted to add one more thing about the feed thickener question, where you showed the Cochrane review that we had done, and there is the forest plot that you showed rightly shows that it reduces the frequency of vomiting in babies. But what the whole result showed is that it reduces the number of times a baby vomits each day, but overall, it does not reduce the time it takes for the symptoms to resolve. It does not lead to any improved weight gain. So it's just, and I'm not undermining the impact of a baby vomiting regularly, especially in view of what the parents' perspectives that I presented today. But that is all it does. It reduces the baby from bringing up milk as frequently as they would without the feed thickener, with no other difference on any other outcome. So it's a matter of giving the feed thickener to make the baby vomit less, with no other difference. And if that is an important outcome for the parent, if it is a parent who's really fed up of, and this is babies outside the neonatal unit, a parent who's really fed up of, washing clothes and changing the baby 5 to 6 times a day, a feed thickener helps. But otherwise, it doesn't make any difference. So it has to be a judgment call on the neonatal unit whether we think feed thickeners are going to help. They're not going to help with weight gain as far as the evidence is concerned. So yeah, it's definitely an area where we need the research study to be funded and for us to do it.
I completely agree. And actually, on that note, so it's 10 to 3 now, so we're spot on time for a tea break. So I might stop there, and we'll give everyone a 10-minute tea break. But in the tea break, if you have any views on that trial I showed, i.e., a trial of omeprazole versus placebo in babies preterm and term, where they get 4 weeks of treatment, please do put them in the chat or drop me an email. We'd be keen on anyone's thoughts, whether they would be interested in recruiting to that trial, whether they think it's a stupid idea, whether we've missed a trick in some way. Please stick something in the chat, because that would be really helpful. I'm going to stay online, but I suggest we all put our cameras on mute and turn our cameras off and go for a tea for 10 minutes, and we'll start back again at 3 p.m. Thank you for all our speakers and for all the questions and contributions. And we'll see, actually, I think it's 3:05 on the timetable. See you at 3:05.
Hello, hi everyone. Welcome back. Hope everyone is nicely refreshed after the short break. So I'm happy to introduce Professor Embleton, who is well known to a lot of us, who's a professor in neonatal medicine up in Newcastle and part of the N4 research team, and he's going to kindly speak to us about the Dolfin trial and give us an update and background. So Nick, over to you.
Good, thank you very much. Can you hear me okay, Chris?
Yep, no problem.
Okay, good. So I'm going to talk about some recent studies that have come out in the last 2 or 3 years on long chain fatty acids, and then give a sort of quick update on the Dolfin study, which many of you will perhaps be part of. And I'm going to show you some data on fatty acid levels in infants with HIE. So that's a study where they classified the babies into a good or poor prognosis based on the MRI, and they looked at plasma levels of fatty acids. And then I'm going to show you some data from 2 or 3 trials where they have been giving supplements of docosahexaenoic acid and arachidonic acid and looking at various outcomes. And then at the end, I'm going to show you some data from the original Dolfin study looking at visual attention in these infants. So as all of you will know, fatty acids are critical components of the diet. They're involved in metabolic response. They're particularly involved in growth of brain and retinal tissues and neural structures. And they may also have roles as signaling molecules. And studies over the last few years have looked at the association of dietary intakes with the incidence of retinopathy of prematurity, sepsis, and particularly BPD, which I'll talk about in a bit more detail. And of course, the Dolfin trial is really looking at the impact of supplements of DHA on neurodevelopment over the first 2 years of life. So lots of very important outcomes. And the QR code there links you through to the SBGAN e-learning module on enteral nutrition, which has been out for about a year now, and I put a link into the chat function as well. So if you want to know more about enteral nutrition, then go along and do that course on FutureLearn. So with fatty acids, there are 2 key pathways. There's the N6 pathway, which results in the formation of arachidonic acid, and the N3 pathway, which results in the formation of docosahexaenoic acid. So the starting point are what are called essential fatty acids. So they're essential, meaning that the body cannot make them, therefore you have to have them in the diet. And the 2 essential fatty acids relevant for humans are linoleic acid and alpha-linolenic acid. And both of these essential fatty acids are elongated. There are a whole series of enzymes responsible for elongation, and enzymes are responsible for the insertion of a double bond, which is kind of critical for the function of long-chain fatty acids. And you will see that linoleic acid goes through a series of elongation steps in order to produce arachidonic acid. And arachidonic acid and some of the intermediary metabolites also produce eicosanoids. And eicosanoids have pro-inflammatory action. And on the right-hand side, the N3 pathway, alpha-linolenic acid is progressively elongated and forms docosahexaenoic acid. And docosahexaenoic acid produces a range of compounds which are called resolvins, and these have a more anti-inflammatory action. And as well as DHA, icosapentaenoic acid is another N3 molecule which is also involved in producing eicosanoids. And there's a lot of discussion around what the optimal levels of icosapentaenoic acid might be. So two key pathways involved in forming these critical long-chain polyunsaturated fatty acids. And we're starting to learn that the ratio or the balance between arachidonic acid and docosahexaenoic acid might be really important. And the optimal ratio may well differ between what you want in the third trimester and what you want in infancy, and it may differ when you're providing fatty acids intravenously as well as enterally. Most fat deposition, as you know, occurs in the third trimester. In the second trimester, you're only depositing about 0.5 gram a day of lipid. But in the third trimester, that's about 5.5 grams a day on average. And the ESPGHAN working group has estimated the minimum fat intake to be around about 4.8 grams a kilo a day, based on the data that shows that humans deposit around about 3 grams a kilo a day in the third trimester. But a lot of the fat that is fed enterally may be malabsorbed, particularly in preterm infants, so you need to include a correction factor as that for that. And then also some of your fatty acids are oxidized and are not used for tissue deposition, so you add in another factor for that. So that's how they came up with that figure. And I've just included here a diagram with the milk fat globule membrane, just to kind of highlight that provision of fat is much more complex than simply giving kind of components like DHA and arachidonic acid. So this milk fat globule membrane you see here is this really incredible structure of 3 layers. And so it has a bilayer when it's formed inside the mammary cell, and then when it's extruded into the milk duct, it picks up a layer of the mammary epithelium. So this is a 3-layer structure. And studied into this structure, as you can see in that diagram, are a whole series of proteins and molecules, which may be very important for function. And when you give formula milk, you don't have any milk fat globule membrane in it, and you can disrupt these milk fat globules if you shake human milk hard. So that's why you're encouraged not to shake breast milk hard, because you can disrupt these membranes. So milk fat globule membrane, it's really just there. People are starting to do studies on it to point out that fatty acids are much more complex than simply looking at the amount of DHA and arachidonic acid. And in the position paper, we estimated that a DHA intake of somewhere between about 30 and 65 milligrams a kilo a day was what was needed with an appropriate combination of arachidonic acid. So these are the recommendations from the ESPGHAN working group. You don't need to remember the specific numbers. It's not really important. As I say, you can go and do this course online, and you can do it for free if you keep to the weekly study program. But if you slip behind and you miss out a week, you kind of can't go back and do it. And after 4 weeks, you're locked out. So then you have to pay for an upgrade. But it's an excellent course, and we've had lots of great reviews. So up until sort of 3 or 4 years ago, what is it we knew? Well, we of course knew that babies needed essential fatty acids in the diet. For about 20 years, there's been a recommendation that arachidonic acid and DHA should be added to formula milk because of concerns that in some infants, elongation may be suboptimal. So formula is now supplemented with DHA to represent about 0.3% of total fat, which gives you an intake of up to about 20 milligrams a kilo a day. So that will roughly give you what you would get in breast milk. The amount of DHA in breast milk is very dependent on maternal diet. So mothers who eat lots of oily fish will have much higher levels of DHA. But unlike DHA, arachidonic acid, you can't really affect the amount that appears in breast milk, and it's fairly consistent. Around about 0.5% of fat is arachidonic acid. And as I said, like fetal accretion of DHA seems to be around about 45 milligrams a kilo a day. So you can start to get an idea that maybe the amounts that were being added into formula milk may not have been adequate to meet the needs of a baby in the third trimester. And also what has been noted is that DHA concentrations in breast milk have decreased over the years, largely due to changes in diet. So we don't eat as much oily fish or meat as we used to. And this kind of led to the first Australian trial done by Maria Macready's, published almost 15 years ago now, where they recruited really quite a large cohort, 650 babies less than 33 weeks. And they randomized the mothers to taking DHA supplements. So this wasn't given to the babies, it's given to the mothers, and the babies then got the breast milk. And what they showed in this was that the brain outcomes in the girls, but not the boys, might have been a bit better where the mums were supplemented. And there was a suggestion of a greater effect in babies coming from lower socioeconomic status. And there was also this finding that at 4 months of age, visual acuity appeared to be better in babies getting mum's milk that had had DHA. But what really excited them was that in this DINO trial, they saw a lower incidence of BPD. And that kind of made sense because DHA is anti-inflammatory and involved in tissue repair and everything like that. So there was good reason to think that the lower BPD may be an important outcome from supplementing DHA into the diet. And this led on to the next studies that were published, say, like 4 or 5 years ago now. So the first one was the NERO study. So Carmel Collins is the first author. This was an Australian study where they supplemented babies with DHA versus placebo. Now, very disappointingly, that was the study that showed an increased incidence of BPD, significant, with a relative risk of 1.13. So it seemed that giving DHA on its own, counter to what you might have expected from the DINO trial, actually increased the risk of BPD. And that then impacted on the Moby Dick trial, which was a Canadian trial from Isabelle Mark and Pascal Lavoie. So that was also set to recruit about 600 babies, but they stopped it early after about 400 babies because of the finding in the Australian trial of higher BPD. And when they looked at their data, they also saw an increased incidence of BPD with a relative risk of 1.3. So I think most people would take that data to suggest that if you just give extra DHA, contrary to what you might expect based on physiology, you don't actually improve outcomes. Indeed, you might worsen lung outcomes. And interestingly, there wasn't really any obvious impact on other outcomes such as RAP or sepsis, although in one of the trials they saw less IVH in the babies getting DHA supplement. But because IVH occurs in the first few days, it's difficult to believe that that was a genuine finding. It may just have been a chance effect. So really the conclusions are that, DHA may also require additional arachidonic acid for beneficial effects. We don't really know the optimal ratio of DHA to arachidonic acid, and it's possible that the optimal intakes change for babies on the neonatal unit to what they might require in infancy. And as I say, there was a lot of good theory as to why they may be beneficial in babies with HIE, particularly involved in neuronal repair, but there really have been very few good trials. So this is data from a recent publication that some of the N3 members may have been part of, where they actually looked at the levels of N3 fatty acids in babies with HIE. It's a slightly kind of complex study. It's an observational study. They looked at 20 babies with moderate to severe HIE who received therapeutic hypothermia. They have a mild HIE group who didn't get hypothermia, and then a control group. And in the 20 babies who had severe HIE, they stratified them into a good prognostic group, so they had good MRI findings, or a poor prognostic group, so they had poor MRI findings. And indeed, 9 of these 10 babies went on to develop cerebral palsy, showing that that was a good descriptor classification, really. So the first finding here is that they could see in the red bars, you'll see that babies with severe HIE have a lower omega-3, N3 index, suggesting that fatty acid pathways might be important in outcome. In this figure here, you'll see the control group, mild HIE, the severe HIE with good MRI, and the severe HIE with a poor MRI on the right-hand side there in red. And up the y-axis, you see the delta 6 desaturase activity. So this is the one of the enzymes in that pathway that inserts the double bond. And I think you can see reasonably convincingly, although it's small numbers, that the babies with the severe HIE have the lowest activity of that desaturase enzyme. And then here they looked at the linoleic acid levels related to those 3 time points in the babies with severe HIE. And what you can see is that the concentration of the essential fatty acid was lower in the babies with severe HIE, so increasing the babies with a good outcome. Now, observational data, we don't kind of know whether this is cause or effect, but I think important data that persuades us that fatty acids probably are very important in recovery from HIE. So the lower levels that we see may be associated with the poor outcome, maybe because of decreased biosynthesis or tissue incorporation was affected in some way. I think, again, emphasizing the importance of trials where you give supplements of DHA. And they concluded that there's obviously a potential role of N3 fatty acids to improve neurological outcomes in severe HIE. This study came out 3 years ago. Many of you will have seen it. This is from Anne Hellström's group in Sweden, where they took 200 babies, less than 27 weeks gestation, and randomized them to getting enteral supplements of arachidonic acid and DHA from day 3 until 40 weeks corrected age, or placebo control. And what they showed was that in the babies getting the supplements, they had high levels of N6, N3 long-chain fatty acids when the serum phospholipids were measured. And they saw no difference in BPD, which is reassuring given the previous data from the Australian Canadian trial. So no differences in BPD, IVH, or sepsis. What they do see was a severe a decrease in the incidence of severe retinopathy in the babies getting the supplements, about half the amount. And here's a upside down kind of Kaplan-Meier, where you can see in orange the control group instance of severe retinopathy, and in blue-gray the instance of retinopathy in the group getting arachidonic acid and docosahexaenoic acid supplements. So I think quite important, persuasive data that there probably really is something here in these babies that means that, you know, supplements or higher intakes may reduce the risk of retinopathy. The next study that's come out recently is a follow-up of the Australian trial where they gave the babies supplements of docosahexaenoic acid. So again, these are babies less than 29 weeks. And the primary outcome of this follow-up study was the full-scale IQ on the Veshler. And out of the 656 followed up, they managed to find 480 of them. And so this trial that sort of raised these concerns about high rates of BPD, when you follow these children up, suggests that the IQ might be a bit higher. So this was significant, 95.4 mean IQ in the DHA supplemented group versus 91.9. It may not look like a big difference when you present it like that, but that difference is of the same order of magnitude for the advantage of breast milk compared to formula milk on IQ. So I think, again, reasonably persuasive evidence that supplements of DHA may be important in brain development in very premature babies. This is a study from Norway, and there are 3 papers from this study that I'm going to show you. The first one here looks at the effect on respiratory function. So again, less than 29 weeks, babies getting arachidonic acid and DHA versus MCT. And what they showed was that in the supplemented group, they had fewer days on respiratory support and lower oxygen demand, so lower FiO2. But they didn't see any differences in BPD. Maybe the study was underpowered for this. And they can show that when they measure the blood levels of arachidonic acid and DHA, they are higher in the babies getting supplemented. So again, persuasive evidence that supplements might be beneficial for respiratory function. This is the same study cohort, but looking at a different outcome. Here they're looking at cytokine levels in the blood. As many of you will know, IL-6 is a key marker of systemic inflammatory response. And what you see in the top left-hand table there are the IL-6 levels on a logarithmic scale, measured at 6 different time points. And in black, you can see the supplemented group. And so if you look at the red box there, the area under the curve, so they take all those data points and they estimate the area under the curve for the first month of life. In the babies getting DHA arachidonic acid supplements, they have lower levels of IL-6, significantly lower levels of IL-6. And you can see slight differences in some of the other cytokines as well, TNF-alpha and interleukin-1 beta. So they conclude significantly lower levels of IL-6 in the babies getting supplements. Again, same cohort, different outcomes. So in this one here, they look at brain maturation using diffusion tensor imaging on MRI. So out of the 120 babies, mean 26 gestation, 92 of them had an MRI. And they look at the differences between the two study groups. If you look at the figure on the right, you'll see this higher fractional anisotropy, difficult to say, in the white matter tracts, indicative of white matter development. And so they see differences in the corpus callosum, the posterior limb of the internal capsule, and various other structures in the brain. So picking out in red and yellow is the difference between the two study groups. And again, same data, but here they've adjusted it for the confounding effects where, sex, gestation, SGA status may have an impact. And again, I think you can see quite convincingly that in lots of the white matter tracts, white matter development seems to be improved in the groups of babies getting DHA and arachidonic acid supplements. And then finally, this paper is a follow-up of the original Dolfin trial, spelt with a PH instead of the F that we have for the current study. So this study took place now about 10 years ago. And in this study, they followed the infants up. They saw them at 6 months of age and again at 4 to 5 years of age. And they report both these outcomes in the paper. So at 6 months of age, they look at what's called the infant fixation shift attention test. And at 4 to 5 years of age, they look at the early childhood attention battery, which involves different components around sort of how well kids can keep paying attention. And they use a measure from the Kaufman ABC. So not big numbers, 33 babies who were tested at 4 to 5 years of age. And what they showed was that for all of the children in this group, these are neonates less than 33 weeks, I think, or with an IVH. They show compared to age-related norms, poor attention. I think all of us see that in the follow-up studies of any preterm baby. And the greatest impairment in sustained attention. But when they look at the differences between the babies who got the DHA and choline supplement, which is what we're using in the Dolfin trial, they saw significant improvements in the intervention group for things called the flanker test and the counterpointing test. So I thought it might be fun just to tell you what these tests look like. So this is the infant fixation shift attention test. So you sit a baby in a car seat, you get them to stare at a computer screen, and hidden behind the computer screen, just above it is a little pinhole where the observer can see what the baby is looking at, which way the baby is looking, left or right. And then you show them this, sort of these 3 lines here, which look a bit like a face. And then randomly, black and white lines start flashing up to the right or the left of the screen, and the infant's gaze is deflected. So the observer is looking at the baby's eyes, and then when the black and white lines flick up, then the babies should shift their attention to these black and white lines. And so the observer doesn't know which side of the screen these black and white lines are flicking up on, but it just records that the infant looked right or the infant looked left. And then you look to see how many times the infant gets it correct. So that's the test of kind of visual attention at 6 months of age. And then in the early childhood assessment battery, they have some tests. Goodness knows who thought of these. So this one's called the visual search test. So you show babies a whole load of red strawberries hidden in red and white apples, and the infants have to sort of locate the infants have to locate those. The flanker test, you have to work out which way the fish is looking when surrounded by mouse, looking either in the same or different direction. Goodness knows who thought of these. I'm sure they had great fun. Sustained attention test, you show them common animals in a sequence of lots of different images, and they have to pick them out. And then the counterpointing test, where you try and sort of trick the infant to look the wrong way. So you show them a dog on one side of the screen, and they have to point to the dog on the side of the screen, but then you flip it around and they're told to point to the opposite side to where the dog is. So those are the sorts of tests that psychologists do to look at kind of visual attention in these infants. And this is the outcome from the studies. And so you can see in black the babies who got the DHA and choline supplements, and in the white boxes of babies on the placebo. And you can see significantly improved attention for the flanker test, the counterpointing test, in the babies getting the DHA and choline supplements, all of them below 100, the standardized mean. So that's what you see on the left, and on the right, it's the same sort of data, but in this, they've just shown you the percentage of infants below the 15th percentile. And again, you can see that the improvements for the flanker test, the counterpoint test for the babies getting the supplements. So a small study, lots of limitations, does suggest that brain injuries associated with later impaired attention might be very important from cognition, for later cognition. And as I say, these suggest that supplements of long-chain fatty acids, DHA, may reduce attention problems. So in conclusion, fatty acid levels, lower DHA levels associated with worse outcomes in babies with HIE. And then data from a whole series of preterm studies suggesting that we really do need to know whether DHA and arachidonic acid supplements or DHA and choline supplements may improve outcomes. I think very encouraging that we're on the right track here. So this is the Dolfin trial that many of you will know. Babies less than 28 weeks, or those receiving hypothermia, so 2 separate populations get randomized to getting extra DHA, some arachidonic acid, choline, and some cytosine bases. And the primary outcome is at 24 months of age. We need to recruit over 500 preterm babies and 470. And this is where we are just from a few days ago. So we're doing great in the preterm group, but the HI group are much more challenging to recruit. We've not had any concerns from the DMEC or the trial steering committee, no increased risks of neck or sepsis in the babies on the supplements. And let's say thank you to everyone who's recruiting. And really just a plug to keep everybody focused and try and recruit as many babies as you can to the HIE arm. They're much more complex and difficult to recruit. We think that HIE rates generally have decreased nationally. But when we presented our slow recruitment to the NIHR and our parent group, there was strong support that we should keep on doing it, and we may well have to extend the trial to get sufficient numbers. So if you are a recruiting centre, please do all you can to prioritise recruiting HI infants. We're not going to get funding for another study. This is our once-in-a-lifetime opportunity to see whether DHA supplements improve brain outcomes in this vulnerable group of babies. And I'm going to finish there and hope I haven't overrun too much. That's the QR code that will take you through to the Enteral Nutrition e-learning package on FutureLearn. And thank you to everybody who has been recruiting to Dolfin, and happy to take any questions if I've got any time left. Thank you.
Fantastic. Thanks very much, Nick. That's really interesting stuff. And yeah, quite exciting. Feels like there's definitely something here, doesn't there, to find. So hopefully we'll get some answers from there. And thank you very much for the link to the education package as well. If you're happy, we're probably going to take questions in the panel discussion towards the end of the session, if that's okay.
Yep.
So I'm just going to introduce our next speaker now. So Christina, who is ST5 pediatric trainee, also up in Newcastle, and also our trainee rep for the N3 as well, who's going to talk to us a little bit about the Hummingbird trial. So Christina, over to you.
Thank you very much. I hope you can see and hear me very well.
Yes.
Chris, yeah, fine, great. Thank you. I'm Christina, I'm from Newcastle, and I'm really grateful that I can share results of Hummingbird Study with you here today, which was a randomized controlled trial that explored human milk nutrition, growth, and the breastfeeding rates at discharge. And that project would be absolutely not possible to be completed without the huge support from my supervisor, Nick, Janet, and Prof. Rankin, and also research team, and specifically our research nurse, Julie, and most of all, without parents. So why was this trial set up in the first place? So we all know that donor human milk is very widely used for preterm infants in neonatal units whenever mums experience a shortfall of the breast milk, or infants experience a shortfall of mother's own milk. And there's been evidence suggesting that there is a benefit of donor human milk compared to formula in terms of the necrotizing enterocolitis outcomes, but it's very unclear what's the effect of donor human milk use on breastfeeding rates. And the evidence that is currently available on that is mostly coming from observational studies, and it's quite contradictory and controversial. So we asked the question whether this research question, this research problem, could be answered with randomized controlled trial. And therefore, we conducted a pilot feasibility study, really, which was non-blinded, and had a nested qualitative component within it, and asked whether extended donor human milk availability, or whether a nutritional strategy using donor human milk for longer in case of shortfall of mother's own milk can make any difference to breastfeeding rate or breast milk availability at discharge. The study was conducted from June 21 till March 23, and it was originally designed as a single-centered, and the recruitment started at the RVI, which is a tertiary neonatal unit that is attached to surgical center that sees around 800 neonatal admissions per year. However, in May 22, secondary site joined in. Sunderland, which was at that time tertiary neonatal unit 2, just very small, and it sees around 350 admissions to neonatal unit per year. And just to mention that PPI was very important to us during that study. So parents were standing at the design at the very beginning of the study, but also were part and active members during the study trial period, and were asking them for opinions, and the parent was a member of a trial steering committee too. Who did we include? So we looked for any preterm infants born under 33 weeks or with a birth weight under 1.5 kilos who were admitted to neonatal units in the first 7 days of life. And that written consent had to be also provided within those first 7 days of life, so early. And our intervention was use of donor human milk to make up any shortfall of mother's own milk anytime from birth until either 36 weeks of corrected age or discharge from the neonatal unit, whatever came earlier. And that was compared to the current standard practice that was at that time in the unit as an established practice, which was using donor human milk to make up shortfall only until the full feeds are tolerated, and if the shortfall occurred later, preterm formula would be used, or term formula depending on the gestation. And we've observed as a primary outcome breastfeeding rates at discharge, by which we mean breast milk availability, and any breast milk availability at either 36 weeks of corrected age or discharge from the neonatal unit. And now on top of that, we looked at multiple secondary outcomes, including different feeding and growth outcomes. We looked at common neonatal morbidities and, of course, feasibility data. And what makes this study slightly different is that it has got a nested qualitative component. So it looks at maternal perceptions as well around donor human milk use. And we hope that that would help us understand this intervention in greater depth. And here you can see just some qualitative methods that we've utilized. And I've conducted 15 one-to-one semi-structured interviews. Parents were, or participants in the interviews were selected with both convenience and purposive sampling. And really the purposive sampling was utilized for about a third of the data to increase the variety of the sample. All the interviews were conducted in person, audio recorded and transcribed afterwards. And in terms of the unpicking the data, 6-step reflex systematic analysis by Brown and Clark was utilized, which is outlined in the panel below. And there were several researchers coding the data. Some of the interviews would be coded by single researchers and some by multiple researchers to increase the triangulation as well. And then the recursive process was utilized as per Brown and Clark, and Michelini already talked about the recursivity of it in her talk anyway, so that was a very similar approach. Here you can see the patient's flow, and we have notified 325 infants that were born under 33 weeks in the study period, in that 20 months, that were screened for eligibility. Nearly 80 of them were excluded at the first screening, either because they didn't meet eligibility criteria, so either had exposure to preterm formula already, or mothers did not intend to express or declined on a human milk use. And also congenital anomalies or babies that had very, very poor survival outlook were not eligible. And then out of the 233 eligible infants, further 51 families declined participation for their infant in the trial. And I must say that there is a group of mothers who perhaps would decline donor human milk, just they did not state the reason why they declined the participation in the trial. And then another significant group here were early transfers. So whenever there were cut pressures, and the infants would be transferred very, very early after birth to a different unit, these infants would not be approached. So ultimately, we've randomized 135 infants that were allocated to the two arms, as you can see, and the primary outcome was analyzed with intention to treat analysis, but also per protocol analysis, where the infants who could not continue on the intervention due to transfer would be excluded from that analysis. And the detailed descriptions is in the boxes on both sides, as you can see. So going to the first demographics, the bottom line is that there were no differences between the two groups, both in maternal and infant characteristics, which is as expected. But I would like to draw your attention to a few data. Looking at breastfeeding experience, you can see that nearly 70% or over 70% of mothers had no previous breastfeeding experience, which is partially due to the fact that they were primiparous, but also those who were multiparous were not likely to have breastfed their previous children. And that just defines the population we have, unfortunately, in the Northeast, because as we know from the data, the Northeast is one of the regions with the lowest breastfeeding rates within the UK. And another interesting data is the fact that most of the mothers who allowed participation of their infant in the study would be living in the lowest deciles of index of multiple deprivation, or would have IOMD in the first 3 deciles. That again just characterizes the population a little bit. Otherwise, we've had fairly similar groups, as you can see. Now, moving on to the primary outcome of the study. So we showed no difference in any breast milk at discharge when we compared the 2 groups in our trial. And that's both with intention to treat and per protocol analysis. What is interesting, though, is the fact that we've increased breast milk availability at 36 weeks of discharge in general in both groups to nearly 60%, which, comparing to NAP data from the previous years before the study was set up, this was ranging around 35 to 40% of infants. So that's a significant increase. Looking at the secondary feeding outcomes, again, no major differences in total mother's own milk offered to the infants during the study period, or also the amount of mother's own milk compared to the total intake would be similar across the both arms. The difference is, as expected, that infants in the standard arm or comparator group would have more formula use, and infants in the intervention group would have more donor human milk use, because many infants would develop the shortfall of mother's own milk during the study period. And another interesting data, just to pick up from this table, is that infants from the full feeds arm would be more bottle fed compared to intervention arm, although that's not statistically significant, but quite interesting, because we know that bottle feeding has got a higher predisposition to kind of lead to cessation of expressing of breast milk. And then when we showed no difference, we looked at also whether there is anything else that we could unpick, any modifiable factor that perhaps leads to less breast milk at discharge, or whether there is a group of mothers that we could characterize, or a group of infants that may have higher chances to have early cessation of the breast milk availability, and hence might need more support. So we firstly, I firstly performed univariate examination of the variables of interest that were identified by the search of the literature, and then those that appeared significant or to have significant association would be then entered into multivariable logistic regression model. And here are the results of that. And as you can see, infant would have 5.2 times higher odds of having no breast milk at 36 weeks if their mother was a smoker, 3.8 times higher odds of not having that breast milk if was coming from the multiple pregnancy, and also probably we can speculate due to the time management strains, 2.6 higher odds of not having breast milk at discharge if mother had all the children at home. So this is a Kaplan-Meier that shows what's the probability of mother's own milk availability in time. And you can see that both arms are very much copying each other up until 40 days. And then beyond that point, it appears that both of the and plateau, but it also appears that 36 weeks might be having a slightly higher probability when tested for the equality of survival distribution, though that was not statistically significant. And part of the study were follow-up data. So the infants that were enrolled in the RVI, which were in total 112 out of 135 infants, were followed up via telephone just to see what was the mode of feeding and what type of milk mum was having for this baby. And we just showed a significant decrease in both arms. Similarly, again, significant decrease in breast milk availability to these infants at 6 and 12 weeks, respectively. Secondary outcomes, again, no difference in sepsis, necrotizing enterocolitis, ROP, PDA, BPD, like no difference between the arms. What is statistically different are other GI problems that included milk curd obstruction and focal intestinal perforation, which is interesting, but it is also very important to interpret that with caution because it's very small numbers and the study is by far not powered for any of these outcomes. But I'm at the moment in the process of just looking at the actual case characteristics just to see what was the milk type and milk amount these infants were receiving at the time they developed the pathology. Growth outcomes, we know from literature that there is slower weight gain with donor human milk use as a supplement compared to the formula, but we have not shown any significant difference between the two arms, which is likely related to the fact that, generally speaking, their mother's own milk availability was similar in both arms, and that was mostly the most common feed. And feasibility data, I think we've shown that there wasn't many mothers that declined donor human milk during the first screening. There's possibility that there's a proportion of mothers who would have declined it if they expressed the actual reason for declining participation in the trial. But that it was quite, generally speaking, easy to recruit to this trial. And our problem were infants who were transferred during the trial because they did not have access to intervention when they were transferred out of the unit, which then meant that it was very difficult to interpret those data and to follow up them too. And only 2 infants received wrong milk meaning when they were supposed to receive donor human milk, they received formula as a supplementation for the shortfall. And now looking through the qualitative results. So I've presented those already in the British Association of Perinatal Medicine meeting. So some of you might know or recognize the themes, but this table just illustrates that we can demonstrate quite a variety of mothers, and I've performed interviews not only with those who developed shortfall, but also with those who never developed shortfall during the trial, just to understand the depth of the effect. And here are the main themes from the qualitative study. Expressing is a struggle, and donor milk effect beyond the use. The sub-themes will be discussed briefly in the following slides. So all mothers identified expressing as a problem. They all met some difficulties, challenges while they were expressing milk in the neonatal unit, and they were related to their internal pressure and in their internal world and interactions with themselves, but also a clash with their original nutritional strategy and interaction with outer world, with the staff, with families. And that was absolutely the same, regardless whether mum wanted to breastfeed or not, or whether mum developed a shortfall or not. All of them felt they were struggling. And then they had to find some strategies how to navigate through the storm. Again, I won't have much time to share with you and read out all quotes, but it is very interesting to see, for example, how this mum felt frustrated when people were applying this blanket approach of, yes, breastfeeding is really good, so please express, because she did really want and did really try hard, but just was struggling, and that was leading to more internal pressure and kind of increased perceptions of failure. And then donor milk effect beyond the use. We've got 3 sub-themes here. The first one is relax and do it, which is quite contradictory to discomfort as a push. And then the third sub-theme is a message about the value of breast milk. And it was really interesting to see how mums either felt that the availability of the human milk in case they developed a shortfall was there, and they felt more relaxed, which allowed them to then express with slightly better effectiveness. And they felt it was making their supply go up. But at the same time, and sometimes exactly the same mother would say that it was not comfortable for her. The thought of using someone else's milk was not comfortable for her. And that served for many as a push, as a motivation to express. And ultimately, after I described the population that we have in the Northeast, it was interesting to watch how a general talk about human milk and about donor human milk worked in a way that mothers described that they would not change their ultimate breastfeeding strategy, and they would still want to formula feed their future children, but they had deep understanding of now how human milk has got lots of non-nutritional benefits compared to formula, which is interesting because generally the value of breast milk was quite poor in the participants that I've interviewed. So going to discussion, and that's my last slide. We've shown no difference in any breast milk availability at 36 weeks of corrected age or discharge in our trial. And we've also shown that RCT was a feasible design. And it's very hard to interpret those results, but one of the speculation could be that it actually supports the fact that donor human milk is a true complex intervention, specifically the fact that we've been able to increase the breast milk or breastfeeding rates in general quite significantly, because it might be that the fact that the human milk was more widely available and was more talked about could have potentially led also to a culture shift in the unit, or to the general knowledge about human milk importance. And unfortunately, in keeping with literature, we've just shown that NICU journey remains a hugely traumatic experience for families and for parents. And from a donor human milk perspective, this was described as an intervention that could provide relief discomfort or promote human milk. And then looking at the limitations, I've already described them. We've also had a predominantly white population, although we really tried hard to include families from other backgrounds. And there was one interview, for example, now I'm talking about the qualitative participants inclusion, because obviously with the randomized control trial, we've approached everyone. But from the qualitative perspective, we've had one interview conducted with that present as well, who served as the interpreter, just to increase the variety of the sample and to understand also the views of other cultures. And from recommendations perspective, individualized lactation support appears to be key to breastfeeding outcomes still. And access to donor human milk is likely beneficial. However, if similar research question was asked again in more robust study, it would be incredibly interesting to see the cost effectiveness of donor milk as intervention. And from qualitative perspective, that would be interesting to study staff perspectives and data perspectives on this topic. And that's all from me. Thank you very much for attention, and I'm ready for the questions.
That's fantastic. Thank you very much, Christina. Really nice trial and data there, and fantastic that you've been able to implement something that's had such a positive impact on a lot of ladies and families and improve your rates. If it's okay, we'll kind of collect all the questions and sort that in a panel discussion at the end, if that's okay and you're able to hang around. So I'm next going to introduce our next speaker, who is Ilana Levine, who is a trainee in Thames Valley, who's going to talk to us a little bit about relaxation and lactation, and whether or not there's any therapies which we can implement on the NICU. So Ilana, over to you.
Hello, I've shared my screen, but I think it might be small. 1 second. Right, is that appropriately sized?
Yeah, we can see your site. Yeah, perfect.
Great. Hi, I am Ilana. As Chris said, I work in Oxford as a grad trainee, and I've just completed a PhD in the University of Oxford at the National Perinatal Epidemiology Unit. So I'm going to present the work, which is probably about 2/3 of the PhD, which is about the connection between relaxation and lactation, specifically with a population of NICU mothers. And the 4 people listed there are co-authors on this work as well. So I don't have any conflicts. So I'm a co-chair of a voluntary organisation called the Hospital Infant Feeding Network. One of my supervisors, Mary Futrell, receives an unrestricted donation for research on infant nutrition from Philips, which is the manufacturer of bottles and teats, but it's not related to this work. And it was an NIHR clinical doctoral fellowship. So the background is that we know the value of breast milk feeding in the general population, and also the particular impact in the NICU, particularly related to necrotizing enterocolitis, retinopathy of prematurity, and long-term neurodevelopment. But we also know that with the NNAT data across the UK, 40% of very preterm infants are exclusively formula fed by discharge. Breastfeeding and mental health are interlinked in a very complicated way, with impacts going in both directions. When breastfeeding goes well, it can improve mental health. Breastfeeding going badly can impair mental health, but pre-existing anxiety and depression can also impair breastfeeding. And we also know that mental health is worse in the NICU setting. So parents whose babies are in the NICU have an increased level of anxiety, depression, and also post-traumatic stress than those after healthy term birth. Relaxation therapies are a group of therapies that are generally accepted to be safe, acceptable to the public, and can be low cost and easily disseminated. So there was a Cochrane review that looked at lactation and expressing specifically, and said that relaxation was a potential therapy that might benefit expressing and lactation outcomes. So I wanted to look further at that. Relaxation itself is a very complex intervention and is made up of lots of different things in different studies. So there can be progressive muscle relaxation, where you tighten and relax muscles, often in a specific way up the body or down. It can be breathing exercises, imagery, which could be specific. So specific to lactation might be imaging of letdown of milk or milk flow. Meditation, mindfulness. It could be directed by yourself, so either with or without assistance, or delivered by a provider. The dose could be variable, so it could just be a single experience or something that's happening multiple times a day. And personal factors might affect how you experience relaxation. So, for example, previous experience, your expectations, and your commitment to doing it frequently. But there is a common goal of relaxation therapies, which is to induce a physiological relaxation response, characterized by reductions in heart rate, breathing rate, blood pressure, increase in temperature, and also a cognitive element of being perceiving that you feel calm and have an increased sense of well-being. So why could this be connected to lactation theoretically? So oxytocin and prolactin are the 2 key hormones related to lactation. And we know that they are associated with stress hormones such as cortisol, noradrenaline, but the relationship is very complex in that there can be relationships. So for oxytocin, for example, is a hormone that is connected with well-being and calmness itself. So they're not necessarily in the direction of stress to lactation. They can be lactation to stress. In principle, neurologically, we could have operant conditioning for letdown itself. So that's something that people have experienced easily, in that a baby cries and you might let down milk. So letdown being the ejection, the muscular ejection of milk. And for mums on the NICU, sometimes the sound of the pump might stimulate letdown. So a relaxation regime that is ritualized and the same each time could potentially be a factor for conditioning. But separately, we know from studies of women who have spinal cord injury that visualization of milk letdown can actually achieve letdown even without sensory pathways being intact from the breast. And then a third kind of pathway of potential impact would be the influence on self-efficacy, the woman's belief that in her ability to breastfeed and express, and potentially feeling calmer and having higher well-being could influence your behavior in terms of how much time you spend expressing or time spent skin to skin. Also, in some of the studies that I'll talk about, the infant was also exposed to the relaxation. So the mothers might be listening to relaxation whilst breastfeeding. So the infant could also hear the relaxation, and potentially that could affect their energy usage and their activity state, for example, their alertness. So I did a systematic review. This is under embargo. It's due to be published next month. So no sharing of the images. So the key points of the systematic review overall was that there are actually a lot of randomized controlled trials in this area. So we included 16 studies with 1,871 women, and of course they also had infants. The relaxation interventions were quite different to each other. Some used simply music, and occasionally that was encouraging the mum to sing, for example, but mostly it was listening to instrumental music, meditation, mindfulness, guided relaxation, and breathing exercises. Some of the interventions were lactation specific with imaging of letdown and milk flow. They were all compared to some kind of standard care, and 3 of the trials were blinded via deception. So when people were recruited, they didn't actually know that the trial involved relaxation. They were just told that it was related to lactation in general. And then the intervention arm were told after they were randomized that there was this extra component. So they didn't know that not everyone got that extra component, and the people in the control group didn't know about the relaxation. And the conclusions of the systematic review are that provision of relaxation, likely used in the grade terminology to mean that there's moderate certainty evidence, increases human milk quantity, increases infant weight gain, and that's specifically in 3 studies where the infant was directly breastfeeding and was potentially exposed to intervention as well, slightly reduces stress and anxiety, and very slightly increases milk, carbohydrate, and energy. So we'll look at those in slightly more detail. The systematic review was updating a previous systematic review in 2016. So the search was from 2016 onwards. It was registered with Prospero. We searched M-Base, Medline, CINAHL, Web of Science, and the Complementary Medicine Database, and Cochrane reviews, but there was nothing relevant there. And the inclusion criteria was that the text had to be peer-reviewed, it had to be full text, it had to be randomized. And we also excluded manual therapies. So for example, things like massage that were purely massage with no other component, and cognitive behavioral therapy would also be excluded. So we were interested in people who are lactating, intervention being some kind of relaxation therapy, comparison being either a control or standard care, and we wanted to know about milk quantity, length and exclusivity of breast milk feeding, content of milk, infant growth, and maternal mental health, so quite a broad range of outcomes. So 16 studies could be included. 14 were parallel group RCTs and 2 were crossover. And they were published between 1989 and 2023. They were a really wide variety of settings. So China, Turkey, India, Spain, Malaysia, America, Thailand, UK, and Iran. And half of the studies were on infants who were full term or normal weight, and half of the studies were on preterm or low birth weight infants or mothers of. And most of them, if you looked at the number of people who were included, used either a specific guided relaxation, which had lactation specific components, or music, so some kind of instrumental music. The risk of bias, I won't go into in great detail, but the green arrows show the outcomes that were at low risk of bias. So that shows that 5 different studies had at least one outcome that was assessed as low risk of bias. And then several of the studies had outcomes that were only assessed as high risk of bias, and then some of them often had a variety. And the studies that had some outcomes at low risk of bias, the outcomes in the same study that had some concerns or high risk of bias, it was often about the data retention. So arms where there was loss to follow-up, significant loss to follow-up, or unequal loss to follow-up in the arms. And that tended to be outcomes which relied heavily on the mothers doing, for example, test weighing of infants for 48 hours or diaries of infant behavior. So the outcome that I was most interested in was breast milk quantity. And as I said, we had moderate certainty that there was an increase in breast milk quantity. Because all of the studies use different timings and different kind of volume equivalents, we had to standardize the outcomes to combine them. So that means that the overall effect estimate is that there's an increase in milk quantity of 0.73 standard deviations, so 3/4 of a standard deviation. But to try and see what that means in real life, if there was a group of mothers that had a mean milk production of 611 grams per day, which was taken as a pooled control, then that would increase to 734 grams per day. So 123 grams increase, which is roughly equivalent to 123 mils. So definitely a clinically significant effect. Infant weight gain was another one that was interesting because it was moderate certainty and it was really consistent between these 3 trials, all of which used quite a similar design and the same intervention, which was a lactation-specific guided relaxation and visualization. And as I said, all of these studies were either in term or late preterm babies who were directly breastfeeding, and the mothers predominantly listened to the recording so that the infant could also hear it. And there was this consistent effect on increased weight gain. So 0.5 Z score, so a Z score of 0.5 increase from baseline to the end of the study. And that would be equivalent, for example, of an increase from the 5th centile to the 13th centile. That's the size of a 0.5 Z score increase. In terms of milk macronutrients, there was high certainty of no difference in protein, so that was very consistent. There was moderate certainty of a small increase in both carbohydrate and total energy, but that was very small. So for example, about 1 gram of carbohydrate per day or 11 kilocalories per day increase in the relaxation group. There was low certainty of no difference in milk fat, but if you see the forest plot on that, it is quite near to being significant with a significant amount of imprecision. So it's possible that there could be a slight increase in milk fat. There were lots of other outcomes. So just looking at a few of the ones that I haven't looked at in detail. So there was moderate certainty of impacts on maternal mental health. So that's a small effect, small reduction in stress and anxiety scores. And an outcome that we would be quite interested in would be duration and prevalence of exclusive or any breast milk, but unfortunately there was low certainty for those outcomes. But the evidence that was available suggested there was no difference in duration and exclusivity of breast milk feeding with relaxation interventions. So this was, the trials are really heterogeneous. So the actual interventions are very heterogeneous, the populations, whether they be term, preterm, the regimes, you know, in some studies, they literally only were offered the relaxation for 48 hours, whereas in others, they were asked to listen to it daily for, 6 weeks or something like that. But surprisingly, even though there's that clinical heterogeneity, most of the meta-analyses only had moderate statistical heterogeneity. And the only 2 analyses that the statistical heterogeneity exceeded the kind of amount that we called significant was in the mental health outcomes. So that means that we can say that there is moderate certainty of a small to medium-sized impact on important lactation outcomes. And of course, we know that relaxation interventions are inherently low risk and low cost to the health service. So we don't need to have a very significantly high level of certainty in the benefit, but there is a significant time cost for the mother. And those with the most potential benefit of increase in lactation and improvement in mental health also tend to have the highest lactation risk, the highest amount of mental health impact, and the least time. So adding another component of stress and pressure of offering a relaxation intervention could potentially have some harm to the mother. So we would probably like slightly higher quality evidence for that specific population, which includes the NICU parents. So I did an RCT within the PhD myself, which had a population of mothers expressing milk after very preterm birth, so between 23 weeks and just under 32 weeks, and they could have 1 or 2 infants. We gave them a 12-minute guided relaxation and lactation-specific visualization to listen to whilst expressing milk. This was an adapted version of the same recording that was used in the 3 trials that I mentioned that had a very similar design, and it was modified with parent input. Control was standard care, and the outcome was expressed milk yield. So parents recorded how much milk they expressed at 3 specific time points, day 4, 14, or 21, whichever day had the highest milk yield of any of the logs that they gave was the primary outcome. It was a multi-centre study, so 4 different hospitals in 3 different trusts in London, in Oxford and in Manchester. It was stratified by gestation, centre and multiple birth, and it was powered to detect a difference of 155 grams, so similar to the output of the systematic review. So we recruited 132 people, which was our target. And on average, their mean gestation at birth was 28 weeks. So that's very significant because it's much, much lower than any of the other randomized trials that have been done before. And half of the group had extremely preterm birth. It was quite diverse in terms of ethnic background and other measurements, such as education and index of multiple deprivation. So, for example, about 40% of the group was from an ethnic minority background, and about a third had not got to university, so they left school under 19 years of age. The relaxation group, those of them who told us how frequently they listened a lot. So there was a median of 3 times a day that they were listening to the recording. And overall, there was no statistically significant increase in the amount of milk. So the adjusted mean difference was 73.9 grams, which was not statistically significant. So then we were looking at why the outcome of the systematic review and our own study was discordant. And this was not a previously stated hypothesis, but it was clear that we thought gestation was very important because we had included that as a stratification factor. So we did a meta-regression looking at the effect of relaxation on milk yield according to the mean gestational age of birth for recruits. And that's the data that's presented here. And you can see in the bottom left corner is my study, Levine, with the lowest gestation of birth, and then a range of other studies. This only covers the ones that are NICU-based studies. And there was a significant relationship, which is unusual for a meta-regression and doesn't include that many studies. So normally if a meta-regression includes less than 10 studies, you might not expect to see a relationship even if one is present. And so gestational age explained 69% of the variability in the effect estimate of milk yield. And on the side, there's a QR code to download the intervention recording or access it and advertise it to parents. So in conclusion, we can say that relaxation therapy can be recommended for lactating people in general, with moderate certainty that there is a positive effect on lactation and mental health outcomes, although it may be small in many cases. We can't say anything about the best type of relaxation or the best dose, and instrumental and relaxing music seems to be as good as anything that is specific to lactation. We know in general that the impact may be very individual and context-based, and several studies did show a kind of dose-response relationship, which was that people who listened more or used the relaxation intervention more seemed to have better outcomes. But of course, that's a non-randomized comparison, so we can't say that that was because they listened more, but rather it could have been other things about them. But also the combination of my RCT with the systematic review suggests that those at highest lactation risk may have the lowest potential benefit. However, in my study, most mothers did find the recording relaxing and valued its presence. However, a significant minority reported that they found it burdensome, that they found it boring to listen to the same thing, and that it was a chore to just try and remember to do it. So the conclusion from my own RCT would be that it can be offered and it's freely available on the QR code, but it's difficult to specifically recommend it in the NICU context. And that's it. The links are other places that you can also get lactation-specific relaxation resources.
Fantastic. Thank you very much, Alana. That's a really interesting study. So I think we're going to move into our panel discussion now. So if anyone does have any questions for any of our speakers this afternoon, please do put them in the chat, and I will kind of relay them and we'll get some answers for you. So my chat has just refreshed. So I think just while waiting for the questions to come in, Alana, I guess given that you've just finished, I just got a question. So yeah, really interesting stuff. So where do you kind of see that going now in terms of kind of with your conclusions about its role in the NICU? Do you feel like there's kind of areas that you can explore, take further? What are your plans?
So I don't plan to spend any more research time on the topic of relaxation, partly because I don't think that we need a great kind of standard of evidence for this intervention because it has such a low risk of harm. And I think that the risk of harm that there is related to finding it burdensome or feeling pressure to listen. And so if we're clear to parents that the potential impact is relatively small, that if they don't enjoy it, that probably outweighs any potential impact that they could have. So I think it's great that we now have a NICU specific relaxation recording, because many of the relaxation materials talk a lot about natural birth and that kind of thing, and can be really off-putting for NICU parents. So it's great that there is that specific resource, but it can be combined with other things like relaxing music, because people did talk about it being boring to listen to the same thing again and again. And as long as people's expectations aren't very high, then if they enjoy it, then that's great.
Fantastic. Thank you very much. So I haven't got any questions in the chat at the moment. Just want to check, Pam, that that's not an issue with my chat.
No, there's a question.
We have now got a question actually from Vicky for Nick. Nick, Vicky's asking about having recently contacted regarding a new kind of product regarding kind of DHA and ARA supplementation, and I suppose Neomega 36, so which is about 100 of ARA and 50 of DHA in that 2-to-1 ratio. I guess she's just asking if you've got any thoughts on this, and I suppose a question for the wider group around, is anyone using it already? So just kind of putting that to you, Nick, and I suppose I could talk about my own experiences as well.
Well, we definitely don't want you using it if you're taking part in Dolfin, because it will screw the trial completely if you start giving babies that. So yeah, if you're part of Dolfin, please definitely don't use it, because we need to know whether this product, we need more data before we can recommend it. And I think that's kind of emphasized by those trials. You know, when we go back to the original trials where we saw DHA supplements to mothers apparently decreasing the risk of BPD, everyone could have jumped on the bandwagon at that point in time and said, well, the babies just need to have more DHA, just give them more DHA, and unbeknown, you would have probably been increasing the risk of NEC by 20 or 30%. So the product, of course, is safe. I mean, it's a food product and it only contains what you might find in other supplements, but we don't know enough at the minute to say you should be using that. Yeah, you have the trial from Sweden, which suggests a decrease risk of retinopathy. But I mean, that's one trial, and you really need that to be replicated in other studies. So I think, you know, there's every possibility that in 5-10 years time we will be giving babies higher amounts of DHA in some form, whether that is by giving the mothers supplements, by using this type of product, by people increasing the amount of DHA in formula milk. I mean, I've been speaking to companies for 10 years now, talking about how you provide the energy in the breast milk fortifiers. And, you know, I mean, all of your energy in the breast milk fortifiers at the minute comes from carbohydrate. And logically, you would say, well, why not provide some of that additional energy as fat? So I know that, you know, companies are looking at the possibility of changing fortifier composition. So I think we probably will end up in 5-10 years time giving babies more DHA than we do at the minute. I think if you jump to using that product, you run the risk of giving them something that may not end up being beneficial. In the context of exclusive breast milk. Well, in the Dolfin study, we specifically chose a supplement that we could give to babies who are getting both breast milk and formula milk. I don't know if that was the question, Ilana. Will you just turn your mic on, maybe?
No, it's more that with the current evidence available, might we not hypothesize that breast milk itself contains DHA and arachidonic acid, and therefore extra might not be as beneficial to exclusively breastfed babies as the mixed kind of population that we have?
It might be, but it's probably dependent on the amount in the mums. And I think with breast milk alone, you're only going to be getting around about 25. So you won't be getting as much as you would get in Dolfin. So if you're getting if you're in the intervention arm and you're getting breast milk with at the higher end, the babies will be getting at the upper end of ESPGHAN around about 65. I mean, this 65 cutoff is just a number plucked out of the air based on some studies that people have done. It's not to say that 65, that going beyond 65 is dangerous. It's just difficult to recommend something if there haven't been studies at that level. But I suspect that what you will see is bit by bit people increasing the recommendations, the amount you give, because, you know, some babies will be exposed to milk with relatively low levels of DHA. And again, it emphasizes, you know, the thing that we know is that, you know, every mother's breast milk is different, and there are going to be some mums, as you know, as Janet was talking about earlier on, some mums who produce milk with very high levels of DSLNT and secretory IgA and everything, where you're not going to get any additional benefit from adding things to it. And you may have mums with very low levels of DSLNT and an IgA where supplements might be beneficial. I think it does make challenges in terms of how you design studies, but fundamentally, you're right. It's difficult to know what the impact of mum's own milk exposure may have on this in this study. You know, there may be an interaction, but we've just had to do a pragmatic study. So yeah.
Brilliant, thank you. And Nick, I was wondering if I could ask in terms of obviously the kind of trials which you mentioned in terms of the DHA, ARA supplementation, which were kind of used kind of in those trials, which kind of predominantly looked at ROP. How did you kind of come about the supplementation within Dolfin, which is kind of slightly different to those trials? What was it that kind of made you choose the supplementation you're using for the trial?
Well, the actual specific combination is based on the original Dolfin study. And so this was a formulation that people kind of cooked up probably 15 plus years ago now. And given that the pilot trial suggested benefit, it seems sensible to go with the same combination. But you're right. I mean, people will ask the whole time whether you think you've got the combination right. And, you know, you could look at those trials of DHA and you could say, well, maybe we're not quite giving enough additional arachidonic acid. But then if you gave a higher amount of arachidonic acid, it's probably going to be suboptimal ratio, given that Dolfin supplements the babies consume until they're 12 months of age. But importantly, we do include choline. So you need choline to make all of your membranes. I mean, you can't just give the DHA. You need a source of choline, and there have been some good studies in the last few years, including isotope studies, showing that preterm babies probably don't get enough choline in their diet either. So I think in Dolfin we feel like, well, we've got the best guess we could have at this point in time. Is it the optimal combination and amount? Probably not. Probably in 5-10 years time you're going to want to tweak it, but you have to go with something. And there was obviously a limit in terms of how high people are going to push it, so we didn't want to push it beyond the envelope of what regulatory authorities are letting us do at this point in time. But that's just a limitation of studies. But yeah, I think you're right. I mean, we're hopeful that we've got a good mix, but you need a trial.
Yeah, it's certainly exciting stuff, isn't it? The fatty acid supplementation. Like I said, it kind of feels like there's something really good here, doesn't there? You know, the kind of numbers in these smaller trials.
Yeah.
So just a question from Christina and Pam. Would you recommend mothers to take a DHA supplement if their baby's at risk of or has BPD?
Well, I mean, in our unit, every baby seems to be getting BPD, so that would include all of the preterm babies who come near a neonatologist at the minute. I think the problem with that is that, again, you've got one study, and we now have this concern that DHA might increase the risk of BPD. I guess it's a bit like, should we be recommending that mothers who are breastfeeding consume a certain diet? I mean, we should be recommending that they consume a healthy diet, where DHA might be a important component, but I don't think we've got enough evidence to say that we should definitely be recommending that to mothers. Only one trial. But as I said in the talk, the fatty acid composition of breast milk is one of the very few things that we think can be influenced by maternal diet. And we would love to know how whether diet or other exposures, if that could change the composition of HMOs, I mean, that would be dynamite. I mean, if you could actually improve the levels of DSLNT, something that stops babies getting neck, that would be really important. But at the minute, nobody really quite understands what explains the variation in the pattern of HMOs. We know that some of the HMO pattern is genetically determined, so the amounts of 2FL depends on the mum's genetic status, whether she's a fucosylator or not. So we know that for one of the HMOs that's true, but for DSLNT, I don't think anybody knows. But yeah, I mean, it's if anybody's looking to get involved in research, then better understanding the composition of breast milk and trying to push it in a direction that makes it healthiest for babies would be great. But at the same time, we don't want mums to get the idea that they need to be doing something very different to expressing. If you start making expressing seem like a kind of chore and you must eat these supplements, then maybe you're going to give a negative message there.
Yeah, that's a really good point. I think Ilana's talk showed that, didn't it? That there kind of needs to be some enjoyment to this kind of process as well. So thanks so much, Nick. There's no more questions at the moment, so I think you're off the hook for a little bit. So just in case any other questions coming, but in the meantime, I've got a question for Christina about your talk. Thanks very much. Great talk, by the way. Thank you. So my question was just really about, obviously you kind of showed some really impressive things with the use of donor milk, especially kind of for longer periods. What's your kind of feeling about how that might impact things like donor supply issues and impact of that on donor banks and
yeah, that's one of the questions that I was actually worried about when we started recruiting to our trial. But I've shown, it was in one of my tables, that in the intervention arm, the median amount of donor human milk that was used per baby through the whole research period up until 36 weeks of corrected age was 1.2 liters. And that's median. So to get the actual feel of the data, which is not presentable now because it's literally just the spread of the data, there were many, many mothers who would develop a shortfall at some point, a lot of them in the first days, and many babies would use very little of donor human milk, and then there would be few super users that kept going with expressing, but were having a shortfall perhaps at around 50% point. So 50% was covered with mother's own milk, 50% with the donor human milk. And there were a few of them, which then ultimately shows the overall use of the donor human milk. So I am not sure. I personally think if this was more liberal and if we just let parents have a say, but allow them to have an access to donor human milk, the impact wouldn't be great. Because I personally feel it's also about the giving up through the journey. So mothers who would have completely stopped expressing or not delivered donor human milk for 7 days to our unit, we would then say, well, this is the point where we're stopping the intervention in the trial. And I think this was pragmatic and a sensible approach as well. So we didn't have any cohort of babies that would be purely using donor human milk just because they were in the intervention arm, and hence the usage of the donor human milk was not so impressive.
Yeah, fantastic. Thanks very much. Jesse Jones has asked, could mums be offered domperidone to continue mum's own milk?
Yes, so domperidone is quite a controversial topic, isn't it? There's not much evidence out there that it's strongly associated with increased breastfeeding outcomes. And as per general advice, when mums are struggling, our special lactation infant feeding team would recommend mothers to go and see GP and ask them for domperidone. And many of them would be using domperidone anyway. But as I say, there's not enough evidence that that's a single intervention that could lead to improved outcomes.
Thank you very much. I can see Alana's got her hand up, who's got the benefit of having a microphone as well. So go ahead, Alana.
Just on the topic of domperidone, I found it interesting that a systematic review of the impact of domperidone is about the same size as the outcome effect that I saw in the relaxation trial. So 90 mils per day is about the change in milk volume that you get with domperidone in systematic review. And then the outcome estimate from my trial was about 70, although not statistically significant. So if we wanted to kind of talk about the potential impact of relaxation, we could say that it's potentially similar to domperidone, which obviously has difficulties because some GPs might not want to prescribe because of the safety MHRA warnings.
Thank you. Nick, you've got your hand up as well.
Yeah, I just want to ask, because we've got a kind of good group of people in the call, what people feel the unanswered questions are around donor milk. We didn't use donor milk until 4 or 5 years ago, and we use it now, and I would find it very difficult to turn back from that state, partly because of the recent trials and Cochrane, and partly because of what Christina is telling us, about this being a complex intervention and potentially having other kind of beneficial effects on how we think about human milk. And, it looks, if anything, that, it probably improves your rates of breastfeeding generally to have this available on your unit. But also, we should be very aware that the Cochrane meta-analysis that says that donor milk reduces the risk of NEC is based on perhaps kind of 4 or 5 trials in the last 15 years. I mean, forget the historical ones, but we've only got 15 trials. None of those were ever powered on an outcome in NEC. So it's legitimate to say we need more data. I'm just interested in, if anybody wants to kind of join the conversation, put the hand up, what sort of trial design we could have. We came up with a Hummingbird design because we found it quite difficult to think we could randomize babies on day 0 to getting formula. But I do have a concern, and we didn't see it in our trial, but it's reported in lots of other ones, that babies on donor milk, where there's very low percentages of mum's own milk, just don't seem to grow, even with the fortifier. So I think there's a legitimate concern that not giving babies enough nutrients when they're just getting donor milk may impair growth and therefore brain growth. So I think it's legitimate that we think about further studies. I'm just interested in what design those studies might be like and whether people have any brave enough to put their hand up and offer an opinion.
Well, I think a kind of I think from our kind of position, Nick and Leeds, I think there is a reasonable question. I think we've used donor milk for a while, and I think my opinion of it has certainly changed over the recent years, and I think that's contributed by those Cochrane analyses, which are now showing there are some benefits with the smaller babies. I think we would again feel reluctant to move away from randomizing smaller babies towards formula. But I think if we're in a position where we've got babies who are fully fed on donor milk and we haven't got any maternal milk coming, we would normally transition those babies to formula because we tend to find they struggle nutritionally. Not all babies, but some. So I think probably a similar design to the Hummingbird would be a reasonable one, where we're looking at how long we continue it. So do we routinely transition or do we continue it for longer? My concern would be growth, but I think Christina's work actually showed that growth didn't seem to be massively impacted, which was quite interesting and reassuring. So I think it'd be certainly an interesting discussion to have.
It might be though, because the babe is getting high amounts of mum's milk, stay in the study, and the babies to mums who are stopping expressing naturally drop out and end up on formula in any case. So I'm not sure we know from our study what we should do. I'm just interested because many people will know that people are trying to get studies off the ground to kind of answer this question, randomizing babies to formula milk or donor milk. I just have a concern that I don't think I would do that for a 24, 25 weeker. I wouldn't put my own baby on formula on day 0, day 1 if there was no mum's milk. I wouldn't do it. So I would find some of the current suggestions difficult, and I wouldn't join that trial. But that's not to say that we shouldn't think about how we resolve this question.
So there's a couple of people with their hands up. Apologies if I get this the wrong way around, but I think Janet got hers up first. Janet, go ahead.
Yeah, so it was just, I think if they're getting a lot of their own mother's milk, then they're probably growing quite nicely, and therefore they're not really a big practical problem. The big practical problem is the babies who are getting virtually nothing or actually nothing of their mother's own milk, who aren't growing, who still remain at risk gestationally and in terms of numbers of days of life, at significant risk from NEC. And it's those babies where I think we have least knowledge about what's actually the right thing to do, where we really are balancing growth against a small but real risk of NEC in the face of using formula. And I think if there is a trial, it's those babies, but we're then getting to a subgroup of a subgroup, where numbers become challenging, and who's going to decide what developmental difference equates to one case of NEC.
Yeah, absolutely. Christina.
Yeah, just add on to what both Nick and Janet said, that looking at the data that I provided, there was no statistical difference. The infants in the intervention arm were trending slightly lower in every single aspect of the anthropometric measures. But at the same time, we know that the median of total volume of mother's own milk compared to total volume of milk overall during the study period was around 70%. So hence, it's a different approach. And therefore, it might be actually the answer to that group of babies that are little and have shortfall. But as Janet said, it doesn't answer the question about 22, 23 weekers who've got completely no breast milk.
Yeah, fantastic. So certainly, I think, yeah, I think it seems like there certainly is an appetite there, Nick, to kind of look into this. I suppose it's delineating that population, isn't it, and what we're asking. So, well, I think we've answered all the questions in the chat, and we're obviously coming up towards the end of the meeting. So I just want to say thank you very, very much to all the speakers today. In the afternoon, thanks Nick, Christina, and Ilana for all your talks and your contributions to the panel discussion. So we do have a feedback form, if possible, please. So there's a QR code in the chat now. And there is a kind of attendance certificate as well, which we will get out to you, which is once you've completed the feedback questionnaire. Thank you very much for coming today and for contributing to the discussions. So just before we dive, Nick, I can see you've got your hand up.
Yeah, just telling everybody to sign up to N3 so they can get notified for future events and all that.
Yeah, absolutely. Thanks so much. Yes, please do sign up to the website. We've got a lovely website, lots of resources on there. There's also a part there where you can contact us as well. So if there are any questions, burning questions that you've had from the meeting today, which we've not answered, please do put it in that, and I'll ensure that we get it to the relevant speakers and hopefully answer your queries from there. We do, of course, have our summer/autumn meeting, which is coming up with going to be something coming out with a save the date. So again, if you subscribe to the website, you'll get all those save the dates. And yeah, we hope that we will be able to see you again in our summer/autumn meeting. Oh, sorry, Nick,
Oh, just to say, there's a BAPM webinar next week. I mean, most people will know about it, but there's a BAPM webinar on donor human milk. I think it's Wednesday next week. But if you go to the BAPM website, you can find it and sign up to it. And I guess it's probably free for BAPM members. But if there are nurses or dietitians who aren't members of BAPM, I'm sure you can register and attend it as well. So I think it's an hour and a half next week. So relevant to lots of people here, I think.
Amazing. Thank you very much. Brilliant. Well, thank you very much, everyone. Have a very pleasant rest of your evening, and yeah, hopefully we will see you in October for our summer/autumn meeting.